Um, we had a problem in here with the microphones on Monday, so hopefully it's been sorted, but if not, we'll take a deep breath and carry on. But we'll try that. So welcome everybody. And I need to bring some housekeeping matters to your attention before we start. No fire alarm expected, but if there is an alarm, obviously follow the emergency procedure. And let's hope it's not raining outside if we have to evacuate. We will be recording this meeting, so if you could speak clearly and use your microphone to speak, that would be useful. Then our online participants can hear, and the public will be able to hear when it goes online and also during the live meeting today. Can I ask you all to make sure your phones are turned to silent, please? Oh, that's good. I'm so pleased. You've taken over from Councillor Nelder, who could always used to be able, or Alderman Freeman Nelder, that always used to have her phone go off. Can I just say a welcome to Jemima Lang. Jemima's here as chair of the Children's Scrutiny, and Viv, you're the vice chair, so you're here anyway. But we felt it was very much applicable. Jemima will not be able to vote, but she'll be able to take part in today. Okay, right. So, any apologies, please?
Thank you, Chair. I got apologies from Councillor Lee Finn, who can't make it this afternoon.
We've also got apologies from Councillor Wheeler, Chair.
Thank you very much. Anybody got any declarations of interest in regards to today's agenda? Natalie?
Regarding, I think it's item 11, which talks about community builders, I declare a pecuniary interest. I've just been recruited to work as a community builder.
So is that a prejudicial or a personal, or whatever they happen to be now? Sorry.
Through you, Chair, it's unlikely you're going to make any decisions that are going to impact on that interest, so we'll take that as personal.
Ross, thank you very much indeed for that clarification. That's useful. Right, okay. So, folks, we have the minutes of the last meeting. Are you all content that they're correct? David?
Just a quick one, if I may. On the minutes on number 19, the work programme, it says the committee agreed that public health indices and winter health preparedness will be brought to the next meeting. And I cannot see it on this particular set of on the agenda. I just wondered if that had in fact been brought forward to the meeting. Thank you.
Through you, Chair, thank you. Yes, so those are the two items we're discussing today, but they've been broken down by the health team into separate segments. So that is the topic of today's meeting. Thank you.
Thanks. I got to page about 140, must have nodded off.
Well, we need to make sure that you see your doctor, so you stay awake a little bit longer. We could make it at least 144, perhaps. Yeah. Okay, no problem. Thank you, David, for raising that. Other than that, can I have a proposer that they're all okay? Thank you, David. And seconder, Phil, thank you. Excellent. And I will sign the minutes accordingly from that. So, brings us on to item 4, which is Chair's urgent business. Anna, we put you on the spot last time about delayed transfers to care, and I just really wondered, how is the situation going, please, up there?
So thank you, Chair. So in terms of today's position, we have seen an improvement in terms of the Cornwall delayed transfer of care, or no right to reside as the new language refers to, since we last met at Scrutiny. So as of today, from a Plymouth perspective, we have an average of 5.7 length of delay. For Cornwall, we have 13.9 length of delay, and for Devon, we have 4.3. I was just looking back at the data, and I think last time we met it was sort of well and truly up into the high teens. So the Cornwall team are working hard, and I think we updated at last committee that actually we were supporting Cornwall with our care hotel. and that actually they were benefiting from some of the beds in our care hotel as well as part of the support for Derriford Hospital. So that continues to be in place. In terms of total numbers, there are 57 people in Plymouth that are fit and ready to leave the hospital, 51 Cornwall people and 14 Devon people as of today. So clearly, colleagues will see there is still significant amount of pressure at the hospital, but I think, testament to the work that's happening across all of the local authority footprints to do the best to manage outward flow.
Thank you for that. And I think one of those statistics which I think we'll all be interested to know about is what's happening about ambulance waits and build up outside of ED. So I think if I could ask you, Anna, to do a little bit of looking into that, and then we can send it round afterwards.
Yeah, so certainly, Chair, happy to liaise with NHS colleagues to provide that data. It's tracked on a daily basis, so it may be helpful for this committee just to look at the last couple of months since we last met so that we can start to see those trends coming through.
Thank you for that. When they're picking up the trends, do they actually pick up why the build-up perhaps is happening? Can they differentiate it's because the person hasn't been able to get to see the GP or things like that? I know Health Watch had looked into that, but I don't know if there's been any other update from the hospital about that.
So I honestly don't know, Chair, but happy to take that as a ask outside of here.
Excellent, thank you. I can update you. If you remember, I had written to a lady called Rachel Pearce, who's the director of, I think, commissioning or something similar like that within the NHS dentistry. And that was quite a while back. I wrote to her and requested a full report back from her, but in September, I finally had it. So we will get it out to all of you. If I say it's a little bit evasive, I don't think you'd be surprised, really, would you? And I think they're basically looking at what will happen when the Integrated Care Board sort of takes over in April. And I think that's probably the safest thing for me to close my mouth now because of a comment I might well make. But very disappointing, I think, that we haven't got too far, really. But I'll send that reply out to you all so that you can have a look at it. Have I got anything else I wanted to bring to you? The only other thing that I would come back to you, and I know we've got it later on in the items on the agenda later on, is if you remember correctly, we were trying to do a mental health scrutiny cradle to grave. And due to COVID, it got postponed and whatever. But it's something that I feel very strongly about. So what I'm going to be proposing to the management board is that gets resurrected and do 2 half days. Probably basically young people 1 week and then adults the next. So once I've taken it to the management board, I will come back to this committee to see who's interested in sitting. But I think it'll be a good half day, if you see what I mean. It won't just be a 2-hour session. You're probably talking a good 4-hour half day session. So we'll make sure you all know, and then if you wish to sit on it, you can do. All right. Jemima.
I just wondered if I could just add to that, just in any forum where I'm talking to young people at the moment, whether it's Youth Parliament or any other thing I go to, I have to say mental health, young people's mental health especially, comes up every conversation I have. So it's really important that we do this. Thank you.
And I've certainly noticed from the fact of being involved with schools, you've got a lot of young children coming into schools that aren't actually what I would call school ready, and that's often because of COVID. They've been isolated. I say isolated at home, but they haven't done that social mixing that all our youngsters tend to do before they arrive. And Natalie, you'll know from your Play Alliance days, that's important, isn't it? So yes, that will all be playing a part. Pauline, you want to say something?
Thank you, Chair. When you do that task and finish, Chair, would it be possible to do a section on service children with their mental health? Because I think that's really important, because they tend to kind of go under the radar a little bit.
No, that's great. Or, you know, when we're sort of sorting out what the actual ask is that we want to find out, that would be certainly a very useful thing to add in. And I'm sure Elliot has made a note of it now already. So thank you. Okay, right. So can I welcome our various officers here? Alan, I think you've got the floor first, wherever you are. Right, oh, there we are. Right, that looks a very salubrious building that you're sat in there, Alan.
Oh, it's Ballard House. Very salubrious. Thank you, Chair, and good afternoon, everyone. The policy brief is a short one this time, but no doubt with the Chancellor's budget announcement tomorrow, we'll likely see fuller briefings going forward. Without going through each individual announcement, it's worth highlighting that Plymouth City Council and our academic partner, the University of Plymouth, were awarded 4.7 million from the National Institute for Health and Care Research. And this funding is to be used to help tackle inequalities and improve resident health as part of the Levelling Up agenda. And there is a welcome seminar with the tomorrow. The other announcement of note was the government's release of Our Plan for Patients in September, which set out a package of measures to ensure the public receives the best possible care over this winter and next. And there's one government announcement not on the brief, but was made on the 2nd of November, which I'd like you to alert you to. And this is the Made with Care campaign, which highlights the opportunities for carers, for careers in care. And this is a national campaign where people are being encouraged to join the adult social care workforce. And this campaign runs until March 2023. So that concludes the policy update. Thank you, Chair.
Thank you very much indeed. There's a couple of things that come out from this, and I'm not too sure how, or whether you or somebody else can help flesh it out. The Health and Social Care Secretary set out the plans for patients. There's that magic figure of 500 million. Do we know, anybody know, whether there's been a penny of that come out of government, or has that all been stilted simply because there's been a change of secretary? Certainly, I'm very much aware that that 2-week expectation was an aspiration, simply because that's all part of the GP contract, and it's very unlikely that a Secretary of State can actually get that done because of the contract. So it's just really wondering, do we have any information about that 500 million, and did we get a penny of it?
That's probably not a question that I'll be able to answer at this stage, Chair, unless Anna wants to. Yep, Anna wants to respond.
Anna's going to take the fall on that one. Yeah.
In terms of the 500 million, we haven't had notification as to what that might mean for us as a local authority yet, so we're still waiting to find out what, if any, allocation will be made for winter.
Excellent. Sue, you wanted to come in.
Chair, I'm looking at the first chunk of the policy brief, and Plymouth's mentioned as getting, I think, 4.7 million. I'd like to know the rationale why Plymouth got 4.7 million when 50 million's going between 13 local authorities, given the state of health that we see, particularly on the west side of the city of Plymouth in comparison to the right side.
Ruth, is that something that you would want to answer on that?
Yes, thank you. So this was a research bid that we had to write a research application for. The maximum that we could get was the amount that we got. So, the 50 million was across the country, and the maximum amount of the bid was approximately the amount of money that we put in for and that we got. So it wasn't based on need as such, it was based on the quality of the bid that was written and that was submitted, and that was jointly between ourselves and University of Plymouth.
Thank you. And will you come back at some time and tell us a little bit more in depth about this
Absolutely.
exciting project? And
We would love to. Yes, we would love
well
to.
done to the team for putting the bid together and us getting that money, because it's a real accolade for us, I think, and thank you to everybody on that. Alan, this may well also be something that you can't answer, but in the NHS set to boost GP workforce ahead of the winter, it's talking about over 1,000 GP assistants. I wondered if in any of the bits that pieces coming out from government, whether there'd been any update on that.
Thanks, Chair. I'm not able to answer that. I did try and do some research on that before I came to this meeting, actually, but wasn't able to find any information. Unless anyone else knows, I will continue to look into that and try and find as much information as I can. But I wasn't able to get anything in preparation for this meeting, I'm afraid.
Lovely. No, I didn't think you would, but so it was just worthwhile asking. We've got Joe Turl coming later, so it may well be that through the integrated care pathway that we might perhaps have a little update on that, so we can ask her when she materialises. So thank you very much indeed. Anybody else got any other questions? David,
Thank you, Chair. On the second part, the Health and Social Care Secretary is mentioning launching the 500 million pension rules to retain people, etc. Do we have any proposed starting dates with all this, or is it just kicking the can down the road again? Thank you.
Statement that the Secretary of State for Health made in September, wasn't it, after she'd been appointed with the past, because she's no longer the Secretary of State, is she? So I think whether it rolls on, that's perhaps something we can make that inquiry and see what that is. So I'm quite happy to see how we can find an answer to that. Okay, David?
Thanks, Chair. That's fine.
Yeah, thanks. Right, thank you very much, Alan, and it was good to see you. We haven't seen you here for quite a while, so thank you very much indeed.
Thank you very much. Cheerio.
Right, now, Ross, risk monitoring report, please.
Thank you, Chair. Not a great deal to update on, fairly similar to the last report you received. So a number of red risks. I think essentially it's a story of increasing demand and reducing resources. Adult social care reform remains as an amber risk on the paper. I understand the self-assessment process will be completed by the end of the year, and you'll have an update in the early part of next year. Chair, I'll leave it at that for the moment, but happy to take any questions best as I can. Thank you.
Thank you, Ross, for that. Immediately, I'm going to be asking you, it says monthly consideration of directorate level financial issues at H Scrutiny Committee. Can I request that, Anna, that we bring that to scrutiny, please? I appreciate our next meeting will be after budgets have been looked at. So in fact, it's probably quite a good time to look at it anyway, but I think we need to make sure that that is also a standing item, that we can have a look at the budget papers, please. Anybody else got anything? No. Anna, you wish to update us?
So I suppose I'd just remind committee colleagues that the month 6 monitoring report went through Cabinet, so that's clearly in the public domain, and I guess and it's at council as well, so it's absolutely there and visible in terms of the position, and absolutely happy just to provide a report into here of that position for you. So yeah, we can do that as a supplementary.
Lovely, thank you very much indeed. Right, failing all other questions? Okay. Ruth, you're going to kindly give us a verbal report on COVID and flu update.
Yes, indeed. So those clearly being the two key winter viruses that we're concerned about at the moment. So for COVID-19, a relatively positive picture. We're starting, well, we have been seeing that decrease now for a little while now. Current figures are looking at around 2.4% of the population that may be affected. That's 1 in 40 at any given time. So as I say, falling down from the peak that we had a few weeks ago. Little difficult to tell where we might go next with that. Obviously, quite a lot of uncertainty around that this winter. Lots of good vaccination levels, and I'll give you some data on that later, but also a little bit of a soup of different variants that we're seeing at the moment, all of them based around Omicron, none of them with any very significant deviations from what we've seen recently with the COVID variants, but it's still a little difficult to predict what might happen next, and we're certainly expecting higher levels to be in circulation during winter time. So then on to flu. So the surveillance that we're seeing around influenza at the moment is showing increased activity across many of the different ways in which we look for flu. And clearly, you'll be aware that, you know, it isn't like the early days of COVID. We don't test everybody for flu. So there are a range of different metrics that are used to indicate what we're seeing. It does look as if we're seeing a sharper increase than we have for the last 3 years or so. Now, clearly for the 2 years of COVID, the reduced social contact, etc., was a very strong suppressant of flu. But even if you compare it to the same time the year before, pre-COVID, you know, we are seeing quite a high increase, but the levels themselves are not very high at the moment. And there's a number, sorry, of other viruses that we expect to see increase around now, which are increasing, but they're not showing signs that are anything particularly different from what you might expect in any typical winter. So I don't want us to get, you know, too worried about those, because there are a number of viruses that we do cope with and we live with, RSV being one of those. So in terms of vaccination, I do have some slides on this which I could circulate afterwards, but they're only words, so there's not much point putting them up at this point, but I'm happy to circulate them. The seasonal vaccination programme, which COVID now fits within that category, is a NHS responsibility, and there's a very strong governance system across NHS Devon, including a health inequalities cell, which has been working with us, with University of Plymouth, to make sure that we're getting vaccinations to where we need to try to increase the uptake levels. So that has been working very well, and we're really, really grateful for the way in which the system has been pulling together to try to get people vaccinated. As I say, in particular around the health inequalities cell, where there's been activity in the areas of lowest uptake, there's been bespoke approaches for certain people, in particular things like some of our people who are homeless and in insecure housing, things like that. So there's been some very positive work that's gone on there. And we'll continue to be targeting those kind of groups of people. And I have more detail that I can circulate later. In terms of the rates, so in terms of the uptake, if we look at flu first, at the moment, it's quite hard to see what is happening this year, because the way the data comes through, it's a little bit in fits and starts, and it's very difficult to compare one year with the next year at this point, because the programmes deliver at slightly different times in different years. But so far, uptake in Plymouth is looking really positive, and the most robust data we've got is in children at the moment, and we seem to be above the England average across all age groups. So that seems positive at the moment. As I say, it's possible that England will start to catch up, because there can just be a staggering in the way the work is done. And certainly we have a background, a history for our flu vaccinations of being very slightly higher than the England average for most categories. So that's positive. We hope to see that continuing. And as I said, the early signs are positive that people are getting vaccinated. In terms of COVID vaccination, as you'll know, I've said before, we have done very well in all of our different COVID vaccinations, right from the first one that was offered. And the same thing is true at the moment. So if I go back a little bit to the spring booster, which was the over 75s and vulnerable only, we had a higher uptake in Plymouth than across England. And if we look at the autumn booster, then obviously that programme is still continuing. So the actual numbers are, well, it's 59%, 59.7% at the moment for Plymouth and 55% for England. So those numbers will no doubt increase because the programme is still going on. But again, we are higher than England. So that is pretty good. And really encouraging, and does, I think, show that we are reaching out to the people that we need to reach out to. as I say, I have a set of slides that gives a bit more detail on delivery in Plymouth, on the eligible groups at for the different vaccines, etc., that I can share. But at the moment, that was all I was going to update on. Thank you.
Thank you very much, Ruth. Something that we've encouraged our staff is in the uptake of the flu vaccine in past years. Are we doing much the same again this year?
Yes, there have been flu vaccination clinics taking place across the council, and particularly targeted to those staff who are frontline and who may, otherwise struggle to access vaccination.
Thank you. Mark?
Thank you, Chair. Ruth, with the different COVID variants that are out there at the moment, are we seeing the potency of them decreasing? I mean, hopefully we are.
So currently they all seem to be following the same pattern as Omicron, which is, as you know, the vaccine is working well for, and we're seeing with the combination of the vaccine and the variant itself, we're seeing low rates of people being hospitalized because of COVID. But it does spread very easily. So we have that trend where the severity seems to be reduced, particularly, as I say, that's partly due to vaccination, not just the variant itself, but it does spread very, very easily. So at the moment, there are no more variants of concern, which is the technical term they use to say a variant that looks as if it might behave very differently. So all of the ones that are circulating in the UK and, as far as we know at the moment, across the world, appear to be relatively similar to that sort of Omicron strain that we're now getting a little bit used to dealing with.
Ruth, I'm just thinking about COVID. I mean, there are a lot of people that would have had their boosters a while back. Presumably, their resistance to the zeroed COVID bug is lowered if they're coming up to needing that autumn booster. So, are we seeing sort of, 5.5 months into having had a booster, more problems coming in? I'm thinking about vulnerable people, but also the general public as well. We're finding them more of a concern.
Yes. Well, there are emerging patterns around that. Certainly, immunity seems to peak. I think it's around 2 months or so, a month to 2 months after vaccination. It does begin to drop off around approximately after that point, but it doesn't. It's important to remember that it doesn't go down to zero. It continues to give some level of protection for a long time, and I don't think we know exactly how long at this stage. They haven't yet been able to announce that the evidence isn't quite there yet, whether we're moving into a 2 vaccinations per year kind of scenario. That's how it feels, as if it might be, given that we had a spring booster and we've now had an autumn booster, but that hasn't been scientifically proven at this point, but that's what it's beginning to look like. And also it's important to say that the immunity that you get from having COVID reduces as well with time. And it seems to be quite individual how quickly it reduces. I mean, as we know, there's lots of different things that can make immunity change from within an individual. And so there's no really hard and fast rules that say you're protected for X amount of time and then it drops off. But you're absolutely right. The longer it goes, immunity does seem to wane, whether that's vaccine induced or because you've actually had COVID itself.
Thank you very much for that. It's always interesting to hear what's going on with that, certainly. Any questions from anybody else? No? Excellent. Thank you. Right. We're moving on to public health commissioning. And John, I just wondered whether you wanted to sort of introduce this item, and then we'll go to Sarah for the bits and pieces. So Sarah, stand by. We'll just hear from John first, okay?
We commission various services, particularly around sexual health, not all of them, which are often administered by Derriford. We also commission the health visiting service. All these things are obviously vitally important, particularly for our younger people, from children right the way up through to teenagers. So, it's, and of course, also drug and alcohol misuse, which are at the tough end of what the health service and social care deal with. So it's a very important area, I think, of public health. It's probably not one that we all see every day. I mean, it's nothing to do with GPs or the basic hospital services, and nothing to do with adult social care, but it is, providing vital services for a lot of our younger people, also monitoring our children's development, and then dealing with people who have issues later on, particularly with drugs and alcohol, which we have quite a high level of on the city, as you will see from reports later on. So I think that's all I probably want to say. I'm sure Sarah will elaborate upon the commissioning of it.
Thank you very much indeed. Sarah, the floor is yours.
Okay, thank you, and good afternoon, everybody. Yeah, the purpose of the paper really was just to provide a reminder, as Councillor Mahoney said, of the wide range of services, I suppose, that are designated public health grant funds within the city. I'm not proposing to go through in great detail. You've had the reports. I'm just going to make a few general overarching points, I think, which are of interest. One is that we use our Public Health Commission budget and our services as very much part of our health and care system. So you will see when you read through around how we commission sexual health services, drug and alcohol services, and the children's services in particular are as a part of the wider system. So in terms of sexual health, obviously we are responsible for some of the services, the sexual health, and the NHS remain the lead commissioner for other parts, but we commission them within a collaborative partnership, an integrated sexual health offer, for example, in terms of sexual health, with the University Hospitals of Plymouth as our main provider. So very much part of a system. Our investment sat alongside NHS investment as part of a system. You will know from many previous discussions that our drug and alcohol complex lives funding, not only do we align with other local or other Plymouth City Council funding, but we invest all of that in our Plymouth Alliance for Complex Lives. So again, a collaborative way to take an integrated system approach to maximising really the value for our money, investing in those services. Similarly, our children's investment, considerable investment, as Councillor Mahoney said, in health visiting, in school nursing and in the family nurse partnership, the key sort of areas that sit within an integrated children's services contract with our health colleagues as well. So again, sitting alongside to maximise integration with those services. And the other key service there is the health improvement service, which is our key main health improvement and early primary prevention investment, which is delivered by Live Well Southwest, and the One New Plymouth is the kind of flag in which we kind of do that. So I think it's really key to get that point that yes, this is public health investment, but it's very much we sit it to maximise the impact we can have within our very much within our health and care system from that. I think the other key thing I would bring out is that investment in the services that we commission saves our system money as well. And I've provided within the report a few examples of that. So, for example, the first one, I've stolen some King's Fund and Local Government Association graphics because they're really helpful, I think. I like a bit of a picture to tell the story. But the first one, for example, I used was around teenage pregnancy. So that's just to demonstrate that for every pound we invest in preventing teenage pregnancy, saves £11 in healthcare costs further down the line. time. So it's a key principle for me for us to all understand and hold on to, that our investments in these services from the public health grant not only provide services for our population that are beneficial to them as individuals and populations, but also saves our system money. And there's lots of evidence, and I've provided some of that there for you, really. I think the other thing I would say is obviously the investment is pretty much around 85% of the grant that we get in goes out to cover the costs of these services that we commission. So I think that's important for everybody to know. The vast majority of the public health grant is spent on commissioned services. The other thing I suppose I would pick out, which Councillor Mahoney has just said, is some of these are very clinical services, some of them aren't. But and I think, so people often don't realise that yes, we do in fact commission sexual health services from the hospital. We do commission contraception services from GPs, for example, and various things. So we are it's important that we remain embedded in that system with our investment, because we can't disaggregate that out, and it benefits us by having that investment within our local system. That was really the overview I was just going to go, but I'm happy to take any questions if there were around the detail provided. Thank you.
Very much indeed for that. Okay, what I just wanted to ask was public health nursing, where it's children and young people. It's talking there about an estimated 10% of children aged 5 to 16 have a clinically diagnosable mental health disorder, and about 1 in 10 young people will self-harm. We have tragically heard of 2 young people whose lives were cut short due to stepping in front of trains recently. And I just really wondered whether, are those figures current, as in within the last couple of years, or are they, if we think about our census data at the moment, of course, we're still looking at a lot of the census data from 2011. So how quickly are you able to update your figures and knowledge, Sarah?
So those figures are population figures that are taken from national average. And what we do is monitor against that. So we're pretty much in line with national average at the last full assessment, I would say, in terms of that. I think, but what I would say is all of the data that is available is still pre-COVID currently. And obviously what we're now in the phase of is to pick up that as you said, that assessment post COVID as we come back into that. So yeah, I think that's probably what I would say, that those are national based, and we follow national, but we need to pick up post COVID our local position and reassess those.
Thank you very much. I've got Patrick, then I've got Sue.
Thank you, Mary. Afternoon, Sarah. Nice to see you, and thanks for an updated report. I just wanted to ask a question around complex needs, and I note all the good work that's going on in terms of trying to help the situation. But when it comes to opiate and crack and drug poisoning and drug-related deaths, they're all higher than the national average. And clearly, we've seen an increase over recent years. But what do you predict moving forward? At what point do you think we would reduce the national average and even may see a decline in this area, sadly, of people in the city dying or affected by drugs?
Okay, well, a couple of things there, really, I suppose. So I think part of the issue we've got locally is that our cohort, particularly of drug users, are older and longer term drug users than in many comparative areas. And so to a certain extent, they will be more difficult and sicker and are in services longer. So, our ageing cohort in that is really quite difficult. In terms of nationally, deaths are predicted to continue to rise, sadly. And one of the responses to that, which is in the report, is we are getting a supplementary substance misuse grant starting that, that started last year and this year, to increase our capacity and increase the level of investment. So over and above what is within our public health grant, to try and look to start to address some of that. We're also looking locally to take a different view through that money and some additional resource on avoidable deaths and drug-related deaths, and how we actually take the learning from that as a system and make sure, if you like, what else can we do. So that approach will be put in place, and we hope that that will pay some dividends for us in terms of the deaths as well. The other thing I think is that we shouldn't forget with regards to this particular cohort is multi-morbidities and different, we don't treat drug and alcohol problems in isolation. They're very often accompanied by mental health and other comorbidities, and it is our alliance and complex size approach that we're addressing all of that. That remains really important, I think, and we're saying that. So I think what I can say is, we are renewed efforts. We've got a good investment plan going forward that's been signed off by central government for us to invest new monies to go forward on that. Different approaches. We'll continue to work really collaboratively through our alliance partners, in going forward with that. So I hope that in part maybe answers that. Can I just also say we've got Gary Wallace, our public health lead on substance misuse, on the call as well this afternoon, because he's going to talk later. But Gary, can I just say, is there anything further you wanted to come in terms of answering that question? Sorry, I'm taking a liberty there, Chair and Councillor, in doing that, but I just want to make sure I haven't missed anything of relevance for you all.
Gary, do you want to come in on this briefly?
Yeah, I'm just trying to turn my camera on. So the other thing to say is that whilst drug use happens across a population fairly evenly, drug addiction, drug problems tends to be concentrated in poorer areas. So we have higher prevalence, but we're kind of broadly in line with our statistical neighbours. So we will probably always show as above the national average, but we're one of the, within our group of statistical neighbours, we actually do better than most. So that's really the only thing I'd add. And the nationally, deaths are predicted to rise because the last heroin epidemic was effectively in the early to mid 90s. People with drug addiction get the diseases of kind of older people much younger. And the cohort is aging, so the average age of the cohort is now in its late 40s, early 50s. But effectively, lots of them have lung disease and heart disease and circulatory problems and liver disease because they've been injecting drugs for so long. So whilst there are plans to mitigate this, it is predicted that nationally they will continue to rise for some time.
Thank you, Gary. Did that answer, or have you still got a quick question?
A very quick supplementary, and thank you, Sarah and Gary, for that. Is there more of a hopeful message for perhaps younger people who unfortunately have got involved in drugs, of actually coming off and being rehabilitated, or are we just going to see the older people, as they sadly pass on, replaced by younger drug users now who obviously will become older in the future?
So that's quite a difficult question to answer, because the nature of the drug market has changed significantly. So we haven't seen a new kind of heroin epidemic, but what we do see is internet access to drugs and a broader range of drugs than was the case before the internet. So yeah, we are not seeing heroin addicts being replaced by younger people in anything like the numbers we used to. But we are seeing emerging patterns of drug use that we don't yet have a really kind of good handle on. But there's also some evidence that people are accessing opiate medication via things like the pain clinic and via GPs. So I think what I'm saying is, it doesn't look like we're going to get an epidemic like we got before, but the market is changing, and it's still too early to say with certainty how that's likely to pan out.
Thank you, Chair. Thank you.
Okay, I'm going to have to say that we need to move on fairly swiftly on this, simply because we've got a slight IT concern that we have to disconnect in a minute, so we'll lose our colleagues online. In fact, it looks like it's gone already. So hold that thought, and we'll be back in a moment to carry on. All right, it's just the IT is having a hiccup. If I go back to, I've got Sue, David and Jemima down, and I'm going to call an end then to this stage because we've got so many bits on the agenda that, you know, it's quite tight to fit in. You don't need to, David? Right, fine, okay. Right. When will we know if we're ready to go? Okay, folks, we're now back online and ready to go. So welcome back, everybody. Those of you online, there was a slight hiccup in that we had to reboot everything. So apologies for losing you. It didn't mean you could go off and have another cup of tea before you joined us. So thank you for not disappearing. Right, so I have Sue next.
Thank you, Chair. It's about the money, actually. I'm reading here in the grant allocated to Plymouth since its introduction has been below the target allocation needed to meet the needs of the local population. So you've got a £3 million shortfall then, and we've had a public health grant in 2020 for 2022-23. It's gone up to 15.9 million. But what I want to know is Plymouth getting its fair share? How are we above or below the mean, and why?
Can I suggest we start off by asking Dr. Mahoney that? Because
Dr. Mahoney,
obviously
why?
that is a political question, basically.
I don't know the specifics on it, but we have always been below. We've been well below ever since this budget was actually stripped out of the health service budget in 2007. I don't know, long term. 12 was it? Right, not that long ago. And we've never had what we thought was the fair shares then. And I know there have been various remonstrations from people around this table and others to try and get it increased. I mean, it has gone up, but we are still below the benchmark. So it is what it is, and it has been thus for so long. I don't know whether Ruth has any idea whether we might get more in the future or how she sees we should be playing this.
Ruth, do you want to come in there?
Thank you. I think over the years, much has been made of this. It has been on our list of the asks of government for a long time now, and as you will see, the changes needed to give us what our needs require hasn't happened. I don't see that that's imminent. I don't see that that's likely to happen in the immediate future. So the way obviously our public health team see it is that our job is to make the absolute most we can of every penny that we get.
Can I just come back in on that? I mean, I think the implication was at the beginning that actually the health service didn't actually give us probably what we should have had, and they had creamed some of it off when it was all in a joint budget over the years. So, you know, I think we shouldn't feel too guilty about asking the health service to perhaps fund certain things if we need it, because that is undoubtedly where perhaps the equity went in the beginning.
I can certainly remember sitting in this room when there was a lot of people here saying Plymouth wasn't getting its fair share, particularly with public health. So, yeah, definitely. And I've got a sneaky feeling, Ian, you might have been the cabinet member at the time. So, yeah, so it's all your fault.
And the situation hasn't improved, Chair.
Thank you. Jemima.
Thank you, Chair. I just wanted to ask about health visiting and whether there was any backlog from COVID for babies born, you know, from March 2020, whether we're up to speed with all of them having had their mandated checks. Thank you.
Yeah, so I haven't got the latest figures in front of me, Councillor Lang, but yes, absolutely after COVID, where we had to deliver the checks in different ways and pause some of those, we're absolutely back into normal delivery and picking up, and that's being closely monitored through the contract meetings, but I haven't got the latest data in front of me, but I can give assurance that yes, we're back into full delivery and catching up on that. We can come back with some further details for you specifically after the meeting. If you wanted to know the performance against those mandated checks, I can get that to you.
Yeah, that would be good, because they're two separate things, being back into normal delivery and whether the babies that were born during COVID have had everything that they needed to have, would normally have had. Thank you.
We'll provide that supplementary information. Thanks. Yeah.
That would be really useful. Thank you very much indeed. Zoe?
I thought, seeing as David pulled out, I'd be sneaky. Can we be assured that when you come to look at the drugs that you were talking about earlier, that within the Alliance you'll look perhaps beyond the Alliance and speak to people that work with drug addicts, you know, to see where the trends are? And spice is actually quite a big thing in Plymouth at the moment, with young people as well, and it's quite easy to get hold of it. My daughter's 16. She has friends who take spice. So I think, you know, it's not just about homeless people, or you know, it's quite widespread and it's quite easily to get hold of.
Sarah, is that something, or Ruth, or is it something that
Yes,
Gary would check?
absolutely. We will. I suspect that Gary will pick up some of this in his session later. So, but yes, I'll absolutely make a note of it.
Thank you very much. Right, well, there's no more hands up. So Ruth, Sarah, thank you very much. I know you're coming back to us in a minute about Thrive, but Ruth, the floor is yours now about life expectancy and health expectancy. And can you just explain to people what the difference between those two terminologies are, please?
Gosh, you'd almost think I'd prompted that, wouldn't you? So I'm just going to share my slide pack, which helpfully has a slide on exactly that. Now, I will apologise that the report is quite long in your pack, but this is quite a complicated subject. I've done some slides to help us to go through this. And could I just also mention that this report was written in response to a motion on notice, Councillor Aspinall, that I believe was raised by yourself. So hopefully you can see my slides. So definitions is my first slide. So life expectancy is an estimate of how long somebody might live. And we tend to talk about life expectancy at birth. So that means if a baby is born into a particular area, how long do we think that baby may live? It does hide quite a lot of detail. It's an average, it's an estimate. And there are, if you actually look at the time that people die, there is a lot more detail within that. So for example, and I put this one in the report, back in 1837, when records began, many children died, as we know. If you survive childhood, then you have a high chance of living to your 70s, and yet life expectancy, that average was 43. So when you look at the figure of 43, this doesn't mean that everybody lived until they were 43 and died at around 43 at all. So it is a figure that hides quite a lot of information. It's useful, but we have to recognise it's got limits. And then the second one is healthy life expectancy. So that is an estimate of how long you would live in good health. And we use contemporary mortality rates. So we use self-reported, people who self-report when they become ill, when they become disabled, when they become unable to consider themselves healthy. So that's even more of an estimate because it does rely on self-reported data as well. And as you commented, this doesn't come directly from the census, but some information is a bit patchy in the number of data points that we have for different areas, etc. So these are estimates. And what that means is that the smaller the numbers, the smaller the area that you're looking at, the slightly less accurate the estimate might be, or less precise, I should say. So there's a little bit of I can tell you a number, but I might also tell you a range that we think it's within. So I'll try and explain the relevant points when we get to the relevant slide. So I'm just going to do a very quick history. I promise I won't be long with this bit because I appreciate we want to get up to date. But this graph here shows you life expectancy from 1841, when we started with really proper thorough records, and the records were death rates in particular, and up till 2010. And you can see this actually comes from ONS, which the Office of National Statistics. So this is fully validated data. And you can see that life expectancy has risen continually in that period. And there's many reasons for that, but things like health improvements in children living for longer, immunisation, antibiotics, all of those things made a massive difference. And also then we started to see significant improvements through health improvements in the older population, so treatments for heart disease, etc., starting to see reduction in smoking, all of those factors playing a role, better hospital treatments, etc. So if we then continue, so I'm basically going to continue the curve and look a little, zone in a little bit closer to modern times. As I've previously reported in my DPH annual report 2019, or back all that time, although we'd seen this gradual increase for a long time, and this darker line is for men, the lighter one is for women. You might want to notice that there is a difference in male and life expectancy. That's one inequality that we don't always mention, but there is a significant difference. We saw a slowing down of the improvement in life expectancy in this blue period, and that was flagged nationally, and also, as I say, in my earlier annual report. And then this little bit on the end, this includes our most recent data, and you can see that life expectancy fell. It won't be any surprise to anyone that that includes the pandemic years. And this particular chart, the way in which the Office of National Statistics do it is they take 3-year averages, and that firstly that gives you a lot of data, so they can be really precise about the estimate, but also it helps to slightly it has a tendency, it smooths the data a little bit. So actually, if we look at the individual years, or that's the slide after the next one, we actually see a little bit more information on that. So first of all, this is a different way of showing this reduction. And I'm plotting here, this is the change for men and for women from one year compared to the next year. So you can see it continued to increase at approximately the same rate. Then we started to see this change. So it was still increasing, but it was increasing much more slowly. And then this is the average for 2018 to 2020. So we had pandemic time within that. We saw an actual drop in life expectancy, particularly for men. And we all understand that. This shows the same thing, but it's annual data. And I put this in to be slightly positive because it shows that 2020 was the worst year in terms of the pandemic, and it does show that 2021 at least had a slight improvement on 2020, but you can see that that's quite a significant drop in life expectancy, taking us back to sort of 2010 figures. So that's what's happening to life expectancy in the country. So as I said, there's lots of data, there's lots of nuances within that average. So another thing I've tried to look at is inequality in life expectancy. And again, this is this is King's Fund data, but this is national data. This shows deprivation deciles, so the 10% least wealthy and the 10% most wealthy at this end. And the two curves, the grey here is for females in 2015, and the light grey here is males in 2015. And what you can see is by 2021, life expectancy, the drop that we saw in life expectancy was the biggest drop was in the least wealthy populations, the most deprived populations. So the difference in those 2 years is virtually nothing if you were a fairly wealthy female, a little bit more if you were a fairly wealthy male, but that change, that drop in life expectancy increases the more you edge towards the more deprived areas. So that does show that, unfortunately, rather than reducing inequality, we've actually seen an increase in that inequality. And again, a slightly different way of looking at the fall in life expectancy by deprivation. And this has male and female, and you can see that the fall, there is a fall for the wealthier groups as well, but the fall is more, so the reduction in life expectancy is more in the more deprived areas. So you know, as you know, a big driver of what we're trying to do is reduce health inequalities. Clearly, the pandemic had a negative impact on that. So if I move us to Plymouth, what I've looked at here is life expectancy, as I say, at birth against, so this is the Plymouth value here, this is the England value here, this is the gap, and I've also compared to our similar areas, the SIPFA areas. And what we saw for females, when we look at the 3-year rolling average, which is the data that is often used, you can see that we had a gap of 0.6 years for females compared to England and 0.6 years for males. So we were below the England average. If we look compared to our SIPFA, so compared to our statistical neighbours, actually we were actually joint best for females, and we were the best for males. So actually, if you compare us to people with significant, with statistically similar populations, deprivation, those kind of factors, actually our life expectancy for both males and females was good. If you look at using 1 year data for 2020, so this is just using 1 year of data. So what I'm trying to do here is really pull out the pandemic impact. And what you can see is actually the gap between Plymouth and England narrowed for both men and women. So it went from being 0.6 to being 0.2 for females and 0.1 for males. Sadly, what happened is that the England value dropped. So the reason why that gap has got smaller is because England has dropped. So it's not, I can't hand on heart say Plymouth has suddenly improved its life expectancy, but unfortunately we saw a reduction in England. Now, what you might have expected would be to see a similar reduction in Plymouth, but we didn't see that. And that's because the impact of the pandemic, our death rate in Plymouth was one of the lowest in the country. And that's why the life expectancy gap between Plymouth and England has reduced. So it's good that it's reduced. It's less good that it's for the reason that the England life expectancy has dropped. It is quite complicated. There's quite a lot of complexity that we see in the data. And I'm not going to go through these in any great detail, but this is the trend with time. And you can see that the Plymouth one, which is the dark green, is the data that we have, but the pale green is these kind of estimates of what we can say is that we know the answer is within these two pale green lines, but we're not absolutely sure where it sits within those. And you can see that it changes really quite a lot. And we can't be absolutely confident that there's a trend going on there. It's not absolutely clear what's happening because of the width of this sort of margin of error. So there is quite a lot of complexity in there. If we do the same thing and look at the inequality in life expectancy, this curve, so the black in these two, this is for females and this is for males on the right. The black is England's inequality. So that's the gap between the most deprived and the least deprived. The good news here is that Plymouth is lower. Now, lower is good in this case because lower is less inequality, a smaller gap between the wealthy and the more deprived populations. So for females, there is actually a statistically very significant reduction. We are significantly better than England in terms of inequality in life expectancy. We are still lower in males, but this little line here shows me that I can't say that it's definite. I can't say it's definitely statistically significant. So there's something positive there. So to quickly summarise life expectancy, it remains lower in Plymouth than England for males and for females, but it is the highest than all of its comparators for males and females. The recent trend is England life expectancy dropping due to the pandemic, but for Plymouth, our drop has been less. So Now we come to healthy life expectancy. There is less data on this. It is a little more complicated and it's even more of an estimate. But we do have something slightly odd going on. So healthy life expectancy for females, this is historically, so this is from 2009 to 11 up to the most recent that we have, which I think is, it's missed off here, 2000, it must be 2018 to 2020. And you can see that Plymouth, which is the red dots here, the healthy life expectancy in Plymouth for females is lower than for England. For males, it was lower than for England, but we have got better over the years and we're now the same. So our healthy life expectancy for men in Plymouth is actually the same as for England, which is really good. But what's going on with female life expectancy? When we look at our comparators, our statistical comparators, it looks quite poor. So this graph here tries to show the total length of the bar is life expectancy. So you can see in Plymouth that's got the green bar around it, green box around it. The total life expectancy is pretty good compared to all of the comparators. So these are all the comparators, and this is England at the bottom. But the length of time lived in good health, which is the blue bar, is actually quite low compared to our comparators. So although women or females in Plymouth are living as long a time as our statistical neighbours, we are spending more of it in ill health than we should be. So what's the reasons for that? Well, this is where it gets very difficult, and I'm afraid I don't have easy answers. There probably aren't easy answers. I go back to a few things. I go back to the wider determinants of health. And as you'll know, these are around lifestyle, they're around social and community networks, but they're also around the conditions in which we live and work. And I also go back to the Marmot policy framework for tackling inequalities, which is around, giving every child the best start in life, up to fair employment and healthy and sustainable places and communities, so that range. So is there something that sticks out for females that's not going well in Plymouth? Well, not really. There are a few things that are emerging. There's something emerging around the employment market, but whether that is the cause or not, I really don't know. But it's something, it's a line of inquiry to look into. So in the economic development in Anna Peachy in particular has been doing some work around looking at this. And we have identified that there are some issues with the gender wage gap in Plymouth being worse than elsewhere. Over half of women earning below the real living wage, lower job density, more part-time work, but also fewer hours that seem to be available for women. So whether there is something around that, I don't yet know, but we can't find any. There is no clear and obvious answer to this, but it is something that we need to continue to look into. So if I can find how to unshare my screen. So I hope that I've presented the data to you. I've shown you that we are doing really well with life expectancy and also in inequality in life expectancy, but there is something going on with healthy life expectancy for women where we're not worsening, but we're not improving as we are for men, and we are poorer compared to our neighbours, and we need to do some more work to understand more. Thank you, Chair.
Thank you very much indeed. Fascinating, absolutely fascinating. I've got Natalie first, then Jemima.
Thank you, Chair. I was just wondering whether or not there's been any research on support for women around menopause, and whether or not that's a contributory factor to the healthy life expectancy. Thank you.
It's a good question, yes, and we know that that's becoming much more. People become much more aware of that. The bit that I don't know is why is that different in Plymouth? So that there are lines of inquiry that we should be following up around that, and we do know that we are struggling with our health services. We do know that people may be less likely to try or to manage to get an appointment for those things that they may see as less important. So you know, healthcare is there for urgent things and for those really big, urgent, important things, but you have to be quite persistent to access it for things that aren't. So it could be that those sorts of things are having some form of an impact. But it's difficult to say anything like that for sure. And so part of what we need to do is look at the kind of suggestions that we get from yourselves, from communities, and see if we can find anything underlying it. So thank you for that suggestion.
Thank you. Jemima.
Thank you, Chair. I know I'm not a substantive member of this committee, so I might not be able to ask for recommendations, but I don't know if it's something that you could ask for around looking at that particular issue about women and trying to dig down into what that's all about and why in Plymouth, because again, things around accessing GP services, or I think what you're saying is that women might be a bit more reticent or, you know, put up with things a bit longer than possibly other people might do. But that's, again, that shouldn't be peculiar to Plymouth necessarily. So I just think that would be very much worth digging into.
Thank you. Elliot, if you can sort of make note of that, please. That's the one thing that's come out so far, really. Viv.
Sorry, Chair, I haven't got any sound reaching me.
Sorry, I'll start again. Thank you, Ruth, for all this data. Normally I would get bored looking at figures and what have you, but I find this really interesting. And also, it's not just about how old a person is or whether they're too old to do this, that, or the other. It's you know, you've included healthy life expectancy. I'd like to know if any work's ever been done, like if you take this list on page 53, how many 80-year-olds are capable of looking after themselves? How many 80-year-olds need care? How much care? And so on as people get older. And also, when people are applying for jobs and what have you, it should never be, oh, they're too old because they're 70 or whatever. It should be how fit they are or capable of doing the job. And I don't think we do enough of that. And I get this because as I'm getting older, people are more worried about my age than my actual physical fitness, which I don't worry about either. So, you know, but that is what happens. And you notice it more as you're getting older. I don't think the young ones realise when they talk about the elderly or whatever, that they should be talking about how fit people are, whether they're eating properly, you know, what they're capable of doing. But I have found this paper really interesting, especially about the areas in Plymouth and how we need really to look into some of these poorer areas where we have the deprivation and how we can help them, because I feel it all starts with the child having a proper education, and going to school is a must, you know, and almost training the parents on how they can give the child the best start in life, because once that happens, everything else, once a child is really educated properly and well, that is a really good thing for them to get out of the deprivation and what have you. But thank you, Ruth, for this paper. I know it's obvious a lot of work has been done on it. So thank you very much. I'll stop there, but there's no question really, just that I did find this really interesting.
Well, Viv, you ought to be referring people to the Equalities Act, because certainly they should not be victimising anybody because of their age. So you just start quoting the
I do it all
age
the
discrimination.
time. I call people ageist and what have you, and you notice it, Mary, as you get older.
Of course you do.
And
yeah, of course you do.
they do not go on enough about how fit the person is, how capable they are of doing a job. I know 70, 80, well, if you knew my age, you would be amazed that I'm still down here.
21 I'd heard, so yes. Can I also say, I mean, there's a whole lot here that we've unpicked today, haven't we, really, Ruth? And thank you very much indeed for that. And I do think Jemima is right. I mean, there's a whole lot, whether we take it from a woman's point of view into whatever, we need to be seeing how and what's happening in Plymouth that isn't happening elsewhere. And I think that that's really useful. And it'll be really interesting to see what those children born tomorrow, what their life expectancy sort of comes out as, really, isn't it? And I think when we look at Marmot and all of the two reports that he's put forward, when we look at Sure Start and what brilliant work Sure Start did, and of course that unfortunately came to an end, we ought to be looking at what we're doing for our young people. So certainly, whilst I'm not totally sure of how to phrase this and put a recommendation, I do think this is something that we need to be looking. And Ruth, presumably, are the census that data that will be coming out over the next few months, etc., may well give us some extra insight to this, isn't it?
Yes, absolutely. I think we'll get some extra insight from that. There's a number of other data sources that we're beginning to be able to look at in a bit more detail as well, which may provide some further insight. As I said, we're building up a picture around the economy and how that's impacting women as well. And also then I think we do need to, I think you used the phrase about what's happening from a woman's point of view. So what is it that women in the city might be able to tell us, particularly in those areas where we know that a healthy life expectancy will be even shorter, because that's the case in the more deprived areas. And actually, Councillor Pengelly's point around actually what is happening at each of the different age brackets is actually really important, because we see that averaging effect. So the healthy life expectancy and the life expectancy is very much an average. So if we look below that to really understand at what age are people reporting that they are losing their health, is it all around the same age, or are there different, do we have several different peaks? Is there any particular life event that we could link to that for some women and therefore intervene? So I have in mind quite a lot of work that we could do, and certainly a recommendation to continue to look into this further and bring a report back would be welcomed.
Thank you. Mark.
Thank you, Chair. Ruth, what accounts for the disparity between men's and women's life expectancy?
Well, that's a very good question, isn't it? I mean, the gap has been narrowing over the years. It's and historically a lot of it was down to occupational health, but in more recent decades, when occupational health has got so much better, then a lot of it then comes down to the difference between men and women's appetite for risk. So if you look at riskier behaviours, they are almost always higher in men, whether that is smoking, drinking too much, driving too quickly, having accidents. There is always that difference between men and women, and obviously that then leads to further ill health. So we have this very odd position where men tend to die younger, but women get more ill earlier, if you see what I mean. But yes, it generally does come down to those factors. Now that we've eliminated things like, well, not quite eliminated, but massively reduced things like occupational risk, it does tend to relate to those behaviours and risk taking.
Pauline.
Thank you, Chair. I'm just sat here thinking about it, and we're talking about women in the city. Has there been any kind of like study to see if there's been any more women in the city that have had COVID over the men? If there's any link to that because of underlying problems that they might have had, which has never been picked up?
Yeah, that's a good question, and actually I think the impacts of things like long COVID are not going to be seen in the data that I'm looking at today, but they may be seen in future. So we do know that our rates of COVID have been, generally speaking, lower than the rest of the country, but you're quite right in that may start to play an impact in the future times. I'm genuinely very hopeful that, given that we've had quite relatively low rates of COVID, and we've had high rates of vaccination, both of which of course should lead to lower levels of long COVID. So hopefully that wouldn't worsen our position. But as against our comparators, statistical comparators. But as you'll know, one of the big issues that's being raised at the moment is around the numbers of people who are not in work due to ill health, and the increase in those numbers does appear to be linked to long COVID, or quite a lot of it is linked to long COVID. So a relevant factor. I hope it won't worsen Plymouth's position linked to the rest of our comparators, but it could still have an impact.
I think one of my concerns as well is with the cost of living crisis that some families are experiencing, that this could also exacerbate what's happening when you've got parents feeding their children rather than themselves. You know, we have to think about what impact that's going to have. So I think it's going to be difficult to get data in, isn't it? But I think it's something that we need to be very much aware of when we look at equalities issues in the city. Okay, I've got no more hands up at the moment, so I'm going to call it quits on this one. Sarah, I'm going to invite you to talk about Thrive, and then after that I'm going to have a comfort break. And then, so Dave, I'm sorry, you're slightly behind, yeah, there. So, but if we ask Sarah just to introduce Thrive, and then we'll have a quick break and then come back to you, Ruth, okay?
Okay, thank you. Hopefully you can hear me again. I'm doing that. So yeah, so I today it was really about just reintroducing the Thrive Plymouth programme to you, panel, and it was really around a reminder. I'm sure you probably don't need reminder, but the Thrive Plymouth is our citywide programme led by Public Health to engage our partners and the city in all working to address the health inequalities that we face in the city. And we've just had a fantastic look at some of those inequalities through the life expectancy data. So there's just a bit of recap in the paper as to what the programme is and what we've actually done so far since we started Thrive. Unbelievably enough, I can't quite believe that I'm going to say this, back in 2014. Hardly seems possible. But I wanted to just update on where we are currently with the programme, bearing in mind that we had to pause our leadership of Thrive and stuff really from a public health point of view in the COVID, for the 2 years pandemic, to work on other things, obviously to have to lead other things. But the good news is that we have brought focus back to this with including a virtual launch of a 7th year, if you like, of focus for our drive on inequalities, which we held in May. And what we wanted to very much do at this time really was to pause, to listen and learn and reconnect, and this is the focus of what we're trying to do this year. So and we're doing those things on many different levels. What we wanted to do and felt was completely appropriate was to listen to our population on what and recognize what we have all been through in the last 2 years with the pandemic. And we felt it was really important to start to reconnect with our partners, with our Thrive Network members, and with our communities to re-establish how are we and what is important to us in terms of what we want to do and focus on, and what health and well-being and inequalities mean to us all. Because there have been some really difficult times through the pandemic and some difficult issues with widening life expectancy differences and stuff, as we saw, and differential impacts of the pandemic, but also some real positives we felt there, some of the community action, some of our the other positive things we've seen across the city. We wanted to really reflect on that. So the purpose and offer and ask in this year is for us and our partners across the city to think about how we talk to our local communities, populations, people we work with, our workforces, around what have the impacts on their health and well-being been of the COVID pandemic, and what do we want to, how do we want to focus moving forward in getting back to thinking about some of those basics of the Thrive and what Thrive was set up on, which is those lifestyle behaviours that we know lead to, and we've we've talked about this in each of the reports so far, lead to those increased risks of ill health and of early and premature mortality. In the paper, it talks about what we're offering and what we're doing there. So I think what we're offering, just to be assured, to our partners is for us all to do some real quality conversations with our, whether that's our workforces, communities, different populations and subgroups. And really start to hear what people want to do. And I'm going to give one example. We've been doing some work through our community empowerment team in Devonport through appreciative inquiry as a technique to talk with the population around what does health and well-being mean to you now after the pandemic, and what are your priorities and how do you want to address them. And it's by having that quality conversation that we will start, I guess, to re-establish our thinking, our networks, and also to inform how we make best use of our resources going forward to sit alongside our communities to help them with improving their health and narrowing the inequalities. So that's probably all I'm going to say. I know we're a bit behind time. So the paper is there. It's an update on where we're at with our programme, if you like, and our annual focus to try and address health inequalities. Thank you.
Thank you, Sarah. John, did you want to come in at all over this?
I don't think so at this point, Chair.
You're happy.
Thanks.
Ian?
Not really a, hello Sarah, not really a question. I think it's really relevant and important because I think the impact of COVID is still very much hidden. So to actually get into a listening mode and consider the impact on people, I suspect there's a lot of people still at home who haven't got back into the habit of visiting, of doing things they did pre-COVID. And I think I guess it will be some research project in the future when we really learn the impact of COVID. But this is a really important first step because I think a lot of people are still suffering, be it they feel antisocial because they've got to have habits of meeting, they've got to have habits of socialising. So not really a question, just more strength to your elbow, Sarah, because I think it's a really important move. But I guess the real impact will come in some period in the future. So I don't expect major answers, but I think it's really important that people out there understand and feel that inquiries are being made and their concerns are being viewed in this way. Thank you, Chair.
Yeah, I think if you think about, we're being told that bus pass uptake is reduced, bus patronage has reduced, things, that people would have gone out and socialised and whatever. I think it's all echoing, isn't it, within the city. So certainly it will be really good to find this out. Right, anybody else got any queries before I say we'll take a 10-minute break, just so that we don't all have to queue outside the loo and things like that. All right. So I'll see you back here. Well, by that clock, it'll be time sort of thing. Okay. Right, we're not quite all back together again, but we'll make a start. And thank you for those that have materialised back as requested time. Ruth, the floor is yours now for the active to thrive, which I'm presuming from the wording there, that means there's something to do with sort of expending energy doing. The floor is yours, Ruth.
Thank you very much. So yes, Active to Thrive fits under the Thrive Plymouth agenda and is all about being physically active. This is about a system response to the challenge, and in the way that we tend to do these things in public health, I've actually got parts of the system here to lead on this. So Claire Benny is here from Active Devon, and she's also has a joint appointment with Active Devon and Sport England. And we've been working closely with Sport England around a particular project that's included in the paper, but also in general around how can how can Plymouth become a city that helps people to be physically active in their day-to-day life, as well as any other ways in which they might choose to be. And so we've been really pleased to work with them. If it's okay, Claire has a couple of slides just to explain some of the things in the paper. So I'm going to hand over to her, and Paul Johnson as well, I think, is in the room. He's one of our public health practitioners who's been working on this too.
Thank you, Claire, for joining us.
Thank you very much. Can you see that?
Yes, we can see it.
Always, when you're presenting on Teams, there's always a point where you can't see. You can't
Yes.
see what you're looking at there. So, as Ruth just said, it's just a few slides to kind of, I guess, bring to life where we are with Active to Thrive, and obviously invite questions as we go through. It, as Ruth just mentioned, comes out of the Thrive Plymouth kind of plan, focused on inactivity being one of those lifestyle behaviours, I guess, that has been mentioned in previous presentations this afternoon, one that we can really look at from a health perspective. So Active to Thrive has a vision, which is Plymouth to be the most physically active coastal city in England by 2034. So I'm hoping that you've all seen this before and recognise that as a bit of ambition for us all. There's obviously governance around this. This is just illustrating that it links to Thrive Plymouth and overall the overall Plymouth plan. We have a theory of change in place, which articulates a number of kind of strategic themes that came out of quite a in-depth piece of appreciative inquiry work throughout 2020 and 2021. So obviously impacted a little bit from COVID in terms of that process, but really understanding what's strong in Plymouth, what can we build on, and what can we do to kind of support that overall outcome about increasing activity levels across the city. So coming out of that is a real understanding that we want to kind of drive a consistent way of addressing this agenda, ensuring that we've got a shared understanding of the value of physical activity. So that real link to tackling some inequalities, that again, very strong from a Sport England perspective as well. And that we can understand those health benefits coming out of being more active. So I'm not expecting you to kind of, I guess, see all the small writing here, and it's a very small snapshot of what that theory of change is, but it's just, I guess, to illustrate the point that there's sitting behind this is quite a comprehensive plan. As Ruth mentioned, there was a specific piece of funding that Plymouth was successful in securing via Sport England, which is the Plymouth Pathfinder project. This has been working quite intensively across 3 secondary schools in Plymouth and really focusing on trying to support children that have experienced adverse childhood experiences or who have special educational needs. And it is effectively using physical activity as a mediator to kind of build resilience in those young people. So there's a real focus on trying to bring youth workers into schools, give children a real great experience of physical activity within the school setting and then out into the community setting to really help those young people kind of manage, you know, a range of challenges and using sport as the kind of medium to do that. That project is will come to an end in July next year, but has so far, I guess, given us some really valuable learning about what it's like for young people within the system and what it might take for us to kind of increase activity levels. But there's been some real kind of real helpful learning coming out of that, and particularly, I guess, for a group of young people that were impacted sadly by shootings in Keyham. That group has kind of come together and has been really supported through activity and through support and kind of almost that kind of informal mentoring with the youth worker that's working with them. So it's been quite impactful, that project. When we look across all the strategic themes, so there's 6 of those, there's been progress across all of those. We're looking at like a 10-year kind of plan here, so we didn't expect that, you know, that there would be significant progress against every strategic theme, but there's certainly across everything we've looked at, we can see elements where the network coming together and sharing is having some tangible benefits. So Paul Johnson, as you said, he's also in the room, and I kind of run the Active to Thrive network, and we've really seen that bringing people together has helped with making sure that things don't land in isolation, and that together we are trying to kind of come together and have multiple partners trying to support some positive outcomes. So we have when there is additional investment. So, for example, the Outdoor Partnership is a new project that Public Health, Plymouth City Council have brought into Plymouth. That project is attending the next Active to Thrive meeting, which happens to be tomorrow, to look at how can that land and how can that unlock the other great stuff that's going on. So the marine, the work around the marine park, or other projects in the city, such as connecting actively to nature, so that that's a joined up way of maximising the benefit. And I think, particularly now with the challenges, cost of living, all of the challenging context that we're in, really trying to maximise what's already funded and where is there already capacity in the system, and a whole range of voluntary partners and organisations coming together is really important and is really driving some positive changes. So in terms of where we are, so we have that plan. We are regularly meeting to kind of review where the actions are and understand when new work's coming in, how do we align against the joint outcomes. As Ruth mentioned, Ruth and I are having kind of regular conversations with my colleagues in Sport England around what's next for the Pathfinder programme. So when that formal funding comes to an end next year, what does that look like? And are we in a position, which we very much hope to be in, that we can secure additional what they call place funding? So funding into Plymouth to kind of capitalise on the learning from that programme. And we've kind of already started looking at a number of ways that we see that going, and exploring that into potentially a broader audience, or certainly how do we maximise the benefit for more children and young people across Plymouth. And we're also looking at how do we really evaluate what we're doing here? How do we make sure that we are consolidating the range of evaluation that happens across most programmes, and we've really captured the kind of case studies and insights so we can really sell the story and really tell the story of how this works, making a difference for people in Plymouth. So that's where we are. I don't know if there's any questions. I can see you all again now, so that makes me feel better.
Does Paul want to come in at this stage, or is he happy to stay quiet? Paul, the floor is yours.
I'll magically appear on screen. But yeah, it was like Claire said, it's really around trying to bring together the partners in the city just to drive the physical activity agenda forwards. It's got so many positives around health and well-being, depending on how you use physical activity to engage with people. And it links well with all the Thrive outcomes that we want to achieve as well. But yeah, we'll open the floor to questions if that's okay, Chair.
Thank you. I've got Natalie, I think, put their hand up first, and I've got Mark and then Viv.
Thank you, Chair. Thank you for that presentation. And I obviously heard about Keam and I heard about Devonport. What areas are you focusing on now? Because you talked about the area you are working in areas, but it's not clear. And are there areas that you're identifying for the future that you already know that are areas that would need some additional support or work? Thank you.
Yeah, so in terms of the Plymouth Pathfinder project, that's working in Stoke Downwell School. Oh no, why can I not remember those? 3 schools. Marine Academy.
Marine, Lipson.
And Sir John Hunt, Marine Academy and Stoke Downwell. So there is then quite a lot of work that's going on around those schools as well to understand what provision exists in the community that those youth workers and the partners that are in those schools can refer out to. So it's making sure that the clubs that exist are able and equipped to really respond to the needs of the young people that we are working alongside. So there's kind of some place-based working around those schools. A lot of the projects and programmes that we have kind of are in multiple places across the city. So there's, for example, Ramblers Wellbeing Walks are in Central Park. There is a programme called Connecting Actively to Nature that pops up in a few different parts of the city. The Active to Thrive programme overall is looking at the 8 most deprived neighbourhoods. So we have mentioned Devonport there, and I know Sarah just mentioned it in terms of Thrive, but that's subject to quite an intensive piece of work to understand what's happening for the community, particularly when we look at the built facilities that we have in Brickfields being a natural place to understand how can we maximise that asset for the people that live around there. So where we're kind of working is very much either led by the need in that area, or there is a specific piece of work and then we look broader around that. So we should and have got lots of mapping that we could show you where there are projects and programs happening all over the place, but we are particularly interested, I guess, as a strategy overall, looking at deprivation, because that tends to be from a physical activity perspective where people are less active. So that kind of research and data will tend to show us that, and that's obviously why that becomes a priority.
Paul, did I hear you mention Plimpton? Or was
Oh,
I just
no,
hearing?
no, it wasn't.
No, that's okay. No, that's fine. I just wondered. Right, Mark, Viv, and then Dave.
Thank you, Chair. Ruth, as you know, in my time as cabinet member for, National Marine Park and Tyneside Lido and Edgecombe, I was always a big supporter of, Tyneside and Edgecombe development. Can you please update us on Tyneside and Edgecombe? I mean, what's different now than 12 months ago?
Apologies, I don't have anything to do with Mount Edgecombe, so I don't really think I can update you on that. In terms of the Lido, you'll probably be aware that we've widened not access isn't the right word, but the range of people using the Lido over the summer considerably, with a range of different events that were there, and making sure that it was, operational and clean and tidy and that kind of thing. And obviously we're developing plans to expand on that for next year now. It's obviously closed now, but looking at plans for next year.
Viv.
Thank you, Chair. Could I just ask Paul a question about the picture there? Paul, did you deliberately choose to sit in front of all those beautiful trees?
I'll try and
As
keep it
trees are
seasonal,
very
councillor.
popular at the moment.
I try and keep it seasonal.
It's lovely. It's a beautiful picture. Anyway, back to the paper. I'm delighted that this has come up, this paper, calling it Thrive Activity and what have you. I firmly believe in, especially, well, all ages should be active, as active as they possibly can be. And I think all my life as a councillor, I campaign all the time for better facilities, to keep our facilities, what we have. I feel every area in Plymouth should have a swimming pool. We've got the Life Centre, we've got one at Marjohn's we can all use. And now in January, one is being started in Plymstock. Great news. I feel we ought to have a velodrome and a cycling track, because cycling is very popular at the moment in Plymouth. And I think we should all aim to protect our playing fields. Like they wanted to put a major road right through one of our big playing fields in Plymstock, and we stopped that. But, there's several reasons why I feel being active is so important. One, if children start early, it does help to keep them healthy and fit, but it's also mentally good, and it teaches them team sports, how to get on with other people. And we do what we can in our ward, Councillor Salmon and myself, to help everyone, not just the youngsters, but all ages take part in sport. We sponsor the girls' football team in Elberton, we sponsor the rugby club, we sponsor the bowling club, we sponsor the netball club down at Coomdean, the Brownies and Guides and Scouts to enter the Devon Tours, competition, 10 tours. We do what we can because I feel it's so important that they get an interest in being active, in taking part in sport, that it gives them something to do and actually keeps them out of trouble. To be quite honest, that the girls' football team, they love it, don't they? They go and they come from all over Plymouth to train at King George V. So I think it's really, really important. And the more facilities we have, the better. Although Mark did mention Mount Edgecombe, for practically next to nothing, you can get the boat over to Mount Edgecombe and walk right through there to Cawsand and back, which is a good activity to do, which costs very, very little. And I can't understand why people don't do that more than what they actually do. But I'll stop there because it's my favourite subject. I could go on forever about it. It's why I became a councillor in the beginning, to improve the sports and activity centres in Plymouth. And I feel gradually, after 30 years, we might be getting there. But anyway, well done, Claire, keeping everyone as active as possible. And thank you, Paul, for that beautiful picture.
Viv, I wouldn't have expected anything different from you because I know how passionate you are about sports. So thank you for that input. David.
Thank you, Chair. I've got about 3% of my questions left, I think, because somebody else has taken over. Just a question on this. Obviously, this is based primarily towards children, young people, etc., which is great. Are we getting the parents and the older people to actually get those children out and doing it? I mean, some of the children, I think you need a pitchfork to get them out of their sort of computers, etc. If the parents don't do it, it's more likely the children won't. So are we actually approaching it on a two-pronged basis or not? Thank you, Chair.
Who wants to do that?
I was just wondering if it was Ruth or myself.
I think it varies. So yes, we are. So the specific Pathfinder project is more targeted at vulnerable young children who perhaps sometimes the parents might be involved, but they perhaps need something that actually isn't their parents. They perhaps need a different a different structure around them that perhaps isn't to do with their parents or their families, that gives them something different from their home life. So it's not always the way that we are tackling it, but there are many things that people can do as families across the city. And as you'll see through all of the different themes around the Active to Thrive plan, many of those are very family centred and lots to do there. I know that, for example, just as a little example, I know our sports development team lead cycle routes, don't they, with mums with young children who maybe are a bit nervous about, how do you take your baby on a bike and things like that, help to get them set up. And of course, that sets them off in good stead for the future. So many of the things we do are about families, but the particular Pathfinder project isn't necessarily.
Thank you, Chair. Thank you.
Thank you. I think one of those things that I think during the summer months that was run was sort of experiencing things like paddleboarding out at Firestone Bay and things like that. And that, I think, hearing from somebody that was helping do the instructing on that, was the enthusiasm and the confidence raising for young people just to be able to stand up on a paddleboard and not fall in. Something as simple, I say simple because I certainly don't think I could stand up on a paddleboard and not fall in, but I think it's just that wonderful experience of doing something that they haven't had to pay for. It's been a project that we've tried. So yeah, I think the confidence raising, and certainly you don't need parents with them for organised sport like that. I've got Jemima and then I've got Zoe. Okay.
Thank you. I'm really pleased to see the idea of being trauma-informed running absolutely through every thread of this project. And I really agree with Viv about, access, and of course we need more, and that's, why I'm really disappointed, for instance, that, there's a proposition possibly that we might be charging people to go and swim at Mount Wise. It's in one of the most deprived areas in the city, and it's a free-to-use facility, which is well used and well loved, and I think, charging for that will put people off. I wanted to ask specifically about this project, whether there's work going to be done around ensuring that we are engaging our looked after children and our care leavers. And I know, you know, obviously some of them might be picked up in the school work that you're doing, but whether there is a bespoke, specific plan to engage those young people so that they can embed the habit of physical activity as well. Thank you.
So absolutely a group that we would like to be doing more with. This particular pilot funding is quite limited and for a small cohort, but absolutely agree that it's something that we could be doing a lot more of. Obviously, we're in a position where there's an awful lot of things that we'd like to be able to do and not always the capacity to be able to do them all. But, you know, as you say, that those groups are definitely a priority for support in the city, and the Pathfinder programme is also targeted at you know, very intense need at the moment, but those groups are definitely ones that we would love to be able to do more with. We just have to see whether we're able to get some funding, to bid for some funding for that, and to broaden the cohort of children and young people that we work with.
Thank you. Zoe.
Yeah, so the Pathfinder, which is obviously incredible, I deal a lot with Marine Academy because that's where a lot of my constituents attend school. How do you define the, you know, how do you know who the vulnerable ones are? How is that measured? Because I'm aware that there's a lot of children, especially since COVID, that don't even attend school. So, and you know, there are lots of conversations about that and the provisions that they have at home, which are obviously costs, cause them to not get what they need. But also, how trauma informed are we as a city? When we talk about ACEs, do we actually know what the extent of those are? But I'm happy to have that discussion at a different time. But it's, you know, the trauma informed care actually is something that, you know, I've done in my job for a long time now, and I'd like to know just how trauma informed Plymouth City Council and the surrounding are, if that's okay.
I'm not sure I can do justice to that in this session, so that may be a session that we want to bring back. But as you know, there's a really strong trauma-informed network across the city. The city has been has declared itself as trauma-informed. I can't remember how many years ago, but certainly pre-COVID, and we have been working across many of the different systems in the city to make sure that they are all trauma-informed and that is embedded. But I can't give you anything more quantitative than that off the top of my head. In terms of how the groups were that we worked with were sought, that was in close communication and conjunction with the school, wasn't it? And the specialists within the school. Claire, is there anything to add?
Yeah, I think we've worked really closely with the safeguarding leads within each school, and a number of those children either are looked after children or they have had some sort of contact with social services as well. So there have been a number, for example, of disclosures through this process where the young people that we are working with have disclosed, you know, some kind of obviously very concerning situations to the youth workers. So I think we feel fairly confident that we've reached vulnerable children and that we are providing the kind of right support there. In terms of that wider piece, some of the wider learning that is coming out of that project is around things like have all teachers had training for trauma-informed approach. So in some cases the answer is yes, they have, and in other cases it isn't. So again, the Pathfinder programme is trying to step in where it understands that there might be a system need and offer things like trauma-informed training for a wider cohort of teachers. And one of the recommendations that has been picked up is that that comes into teacher training at the very earliest level, so that teachers that enter, you know, their first role, they've already had that training. So it's trying to spot where is there something in the system that can be improved, so that obviously all children benefit from that, as well as the specific children that have been identified through the programme, if that helps.
Thank you very much indeed. Thanks for that insight, and it certainly sounds as though it's something that we need to be watching and see how we then progress this from it being, particularly the Pathfinder being a one-year programme, as to how we can then progress that for future, can't we, for the young people. thank you for that. I'm now going to move us on to Children's Healthy Weight Plan. This is quite an exciting thing. So Julie, thank you for joining us online. We've got Dave in the room. So I'm not too sure who wants to start on this.
Thank you. I was just, there we go. I think, is that coming up all right? Yeah. Okay, so I'll just give you an overview.
Sorry, Dave, do you want to bring the microphone that little bit closer to you?
Okay.
Thank you.
Sorry, can you hear me? Yeah, okay. I'm going to give you an overview, and I'll try and get through that. I'll skip through that as fast as possible so you can have some questions. But I just wanted to just say that in terms of the last item, this piece of work has got some very strong links to that, and we're having ongoing conversations with Claire and her team about how we maximise kind of what they bring to the city through this plan. So there's some very, very close links. We talk to each other, and there's some good opportunities that come from this piece of work. So I don't want to repeat what you may have too much, what you may have read, but I thought it might be useful, given so many items today, to just sort of spend a couple of minutes just to sort of frame this item. So this is a 10-year plan, and we've really spent quite a lot of time going through as much of the research and evidence around what's been looked at over many years to try and inform where we want to go through. Where we want to get to. And a key bit about this was some appreciative inquiry that we undertook a few years ago. And I'll kind of say a little bit more about that in a second, but that was with our some of our families in Plymouth, and it was incredibly insightful, and it's resonated with a lot of the research to take us on the journey we want to go through now. You also touched on earlier about issues around some of the issues around quality of life, and stuff like that. And it's really clear that issues around obesity can have long-term health impacts on many people, and and trying to deal with this at the earliest possible age, so children and young people, is a really good preventative kind of approach. So for the city, childhood obesity and excess weight are significant issues. Living with obesity has significant implications at times in relation to diseases, diabetes, stroke, coronary heart disease, cancer. In terms of young people, we get implications around things like bone and joint problems. There are breathing difficulties through issues like sleep apnea. There are consequences and also issues around stigmatisation, bullying and low self-esteem. So it is a live issue. It's a very sensitive issue. This is a very difficult issue. People, we're all different shapes and sizes. There are all different reasons for this. And we want to change the kind of paradigm around thinking about this. A lot of people are left feeling very guilty about this sort of issue, and that is not a strong motivator. It's also, a lot of people often feel helpless. The pattern of dieting for most people completely reflects a chronic relapsing condition that we all go through. So most of us in our life probably attempt about 800 diets, and somewhere or another end up in the same place again. So I think it's a kind of very challenging and very difficult issue. But I think what we're proposing gives us the best opportunity that we may have ever had, I think, in terms of being able to get some real positive outcomes. So taking that into account, though, I think where we currently are is that as a city, the latest data that I've put up there shows that in terms of the NCMP, which is National Child Measurement Programme, so that's an annual, or was until we had COVID, an annual process whereby we weigh and measure children, shows that at year receptions, so that's year receptions, that's when they're 5, we have more children that are measured as a proportion of our population as being overweight or obese than England. However, the good news is that since the last full survey, we have dropped, but we still remain higher. In year 6, we are lower than the England average, but it's still an increase on where it was in year reception. And since the last full survey, we've gone up by about 3%, which is actually in line with how England have gone up. It's worth noting that that measure is actually a measure which is relative to an England average, and the line is generally going up. So it's not like this is going down, it's just whether we're going up at a higher or lower rate. So the implication is quite clear, is that this is still moving in the wrong direction, putting it bluntly. And I've added in here the adults data, which shows that across, for the Plymouth adults population, the figure is 62%, which is lower than the England average, but is showing that 2/3 of the population are being weighed, are at a weight which would be classified as overweight or obese. So this is a significant issue. Some work that was done many years ago by Foresight, even then modelled that the cost of that by 2050 would be £10 billion a year to the NHS, which is a massive amount of money. So again, there's quite a lot of significant kind of implications around this. But the key thing is that this is moving in the wrong direction. And if we're going to do anything about it, we need to probably step back and try and look at all the levers we can use locally to try and influence this. Not all of our levers that have an impact are down to us. Some of them are at a government level, and you'll be aware of stuff around salt, sugar, fat content of products, some sort of decisions around kind of advertising, stuff like that. But we have some influence on some of that, and we have some influence on planning decisions, which the council has, and some of those things are part of a whole system approach. When we did, when one of my colleagues, Gemma, did the appreciative inquiry, it kind of very much opened up incredible insight to what was going on. This was undertaken with families that at the time would have been eligible for a weight management service. We decommissioned that service because the outcomes were not good. In fact, they were very poor. The thing that people were getting out of it the most was coming together as a group. But in terms of what it was supposed to do, in inverted commas, there wasn't much movement. So we talked to the families, had conversations with them. And what became very clear was just the level of complexity that was involved in those families' lives. So we had issues of long-term conditions. This was included, as well as like that being reflected in terms of children and adults. So there was neurodiversity in terms of maybe issues of autism, for example, or around mental health issues. Then there was high levels of anxiety, mental health. There was little significant issues around low income and choices people could make around based on low income. There were issues around family dynamics. There was issues around trauma. There was issues around access to activities, etc., which are linked to cost again. So there was a significant amount going on, and when you're talking to people about, well, why didn't you come to the session and that, this seemed to go right down the agenda, because it's like, well, I've got my lived experience, I've got all of this to deal with as well. So when we're talking about why don't people engage with things, this is really important to get your head around, I think. And I think one of the things around the plan is about trying to provide better conditions and a better environment for people to begin to kind of take up what's going on. So we are aware that there is a lot in the city, there's a lot of opportunities in the city, but actually engaging with them is not easy. And we see that compounded by issues of deprivation, so we see significant inequalities in relation to this as well. So, let's try and go to the next slide. So, for the plan, we needed to be bold and have a real kind of ambition of being transformational. The Foresight report in 2007 identified 108 different factors that influence weight, 108, which clearly indicates that there's no single solution, and clearly indicates multiple solutions for multiple, which are bespoke to different families because of different needs. So we needed to take account of the fact that this is complex. That leads you to a whole system approach. It's got to be whole system. We've got to kind of harness what we have across a wide system. We use the word compassionate. We've worked with colleagues in different parts of the country around this, but compassionate means that we are minimising, we want to minimise stigma, and promote opportunity through that, opportunity to engage in getting a health benefit or health gain. And the commitment is over the long term. And I think from elected members' points of view, the thing that we really need with this plan is understanding, I suppose, as well as challenge and support about the necessity of it to be a long-term plan. So that if we're going to turn the corner around this, we need the time to do that. The way we want to go about the plan, the way we're doing the plan, is to focus on success criteria, which we want to see in 10 years' time. And the elements to that we've picked out that we feel are really crucial are linked to current kind of indicators that we use, but we want to see big difference in 10 years. So they're linked to things across the life course, 0 to 19, in terms of young people. So we're thinking about infant nutrition and breastfeeding, and the metrics we have around breastfeeding at the moment don't put us in the best place. So we want to be better than England in all of them, which is highly ambitious, but certainly gives us like the direction of travel of where we want to go. With the NCMP data as well, we want to be better than England. And by working over this over the long term, we feel that we can kind of move in that direction. We have criteria, success criteria linked to conditions that children, young people present in hospital, secondary care, which we would like to see a reduction of. So that's things linked to, I was talking about sleep apnea, which is breathing, joint conditions, the type of concerns that come up that are pre-surgery, that mean that maybe an operation can't take place because there needs to be more work done before, because there's concerns around the issue of weight for that child. We also want earlier information, advice and support available to some children and young people where genetic or biological conditions would make them more vulnerable to a higher weight. So genetics and biology do play quite an important part in this. That doesn't mean it's kind of certain that people will have an outcome which is negative around that in relation to weight, but it means that with other factors like within the environment and the choices they can make, that can certainly play a significant part. So actually, people being seen by some of the professionals in our city do not always raise issues about thinking about things like being active or nutrition, and that in the context of being vulnerable to weight conditions. So we have a new Tier 3 pilot service, which is based on offering a service to children and young people that have significant health problems related to their weight. And a lot of them have these comorbidities, these different illnesses that go alongside it, or a genetic or biological reason why that might also have been the case. We've got links to the Active to Thrive, so we're looking at the vast majority of the population meeting the Chief Medical Officer's guidance within the 10-year period. There's a new schools food audit that we were part of, one of the local authorities that were piloted for that this autumn, and we want to have every single school achieving that by the time we get into the 10 years. In fact, we wanted to push that a bit earlier in when we think we should be able to do that. And that's particularly true, I think, for our secondary schools. Primaries have got a kind of a more captured audience, I think, if you want to put it that way, in terms of what children eat. And I think we see that reflected in our NCMP data. And we've also got a lot of qualitative stuff, which is part of the way we want to work. So we want to work in a way with this plan, which is not about just sort of engaging with children, young people and families at certain points of the year. This is going to be an ongoing process. The key thing around this is around learning all the time, and we're going to set up ways of doing that. So there's feedback coming through all the time. So from a systems management, so this is about managing the system. We want to utilise something called a human learning systems approach. We're fortunate in Plymouth and that Gary, who's going to speak after me, is kind of one of the leading experts in this in the country, actually. So we've got very close and proximate kind of advice on how we can approach this. But the key thing is focusing on learning. So it's learning across the system. And that learning's feeding into how do we meet the needs within a complex system. And if you think about it, it makes sense. If you have a plan and you don't adjust the plan all the time because it is a complex system, things change, it becomes very difficult. So we need to be quite agile in how we deliver. A good balance between services and community assets and wider stakeholder roles. The thing about this plan is it's actually not overly dependent on commissioning new services. It's very dependent on building community asset at either an individual, family or community level. Putting it bluntly, people might engage with a service for an hour a week if they're lucky, but they have a lived experience which is 150 or 60 hours a week. So what happens in that space is critical. So we need to kind of think about enabling individuals, families and their communities to have better opportunity to take up what's there and feel they can. And we're thinking of some sort of quite innovative pieces of work to delegate opportunities to individuals and families around what they do, and there could be a little bit of money that follows them on that. I've noted that new investment is low, relatively speaking. It's in the report, it averages about 20,000 a year. And this plan is not dependent on it, which given the kind of current environment means that it's not risky. So, yeah, and it needs to be delivered in phases. So that will be new. And again, I'll reflect back into what the report says. I'll just finish by saying all the key research and evidence does support this approach. So I'll leave that there for the moment and then give you a chance to ask some questions. Sorry, it's a bit longer than I thought.
Thank you. That's great. Jemima, I'm going to give you the opportunity first, because obviously, it affects a lot of children and then the adults. So I've got Jemima, Ian, and then Joey.
Thank you. Thank you very much for that, David. I just wondered what more we can do around Healthy Start, because, if we were to improve the take-up of Healthy Start, surely that could be a really big factor in helping all the problems that you've identified and spoken about. I don't know if we know where has done it best in the country and how they've achieved it, because I don't know if people know about Healthy Start, but it's free milk, free fruit, vegetables, canned, frozen, vitamin drops for children up to the age of 4, as it says on the tin, Healthy Start. And it's not just Plymouth, but it's hard to get people to take it up, isn't it? And we need to be doing more as a city to make sure that the people who are entitled to that Healthy Start get it.
So I mean, that's absolutely right. There was a bit of a hiccup in terms of change of system, which didn't help. But I think the thing about the plan, I think, which provides an opportunity for us to do that is that the building blocks of the plan in the first phase of the plan is about creating a shared endeavour across all those that have a stakeholder role. And I think things like Healthy Start can be promoted much more effectively through that. It's about hearing about this from every possible corner and people being enabled to support families to then kind of seek it. So I think in the past, I think we could probably say that maybe that's been too narrow in approach. So we need to broaden it out, and I think that will be the main way that we'll do that, alongside improved comms and messaging around it as well.
May I ask one more question, just around school meals? Again, that seems a kind of a no-brainer in terms of if we were able to make it so that more children could access school meals, then we would know what they were having, and again, be able to do more around introducing those habits around healthy eating. Or is that an assumption that's not correct? I mean, if there were, I know that's not something we can do at local authority level, unfortunately, but if it were an offer that, we knew that all children got free school meals at primary school, for instance, then we would know that they would have access to at least one very, healthy, balanced, nutritional meal a day. And again, that should help with what this plan is trying to achieve.
Yeah, again, I think kind of early years and school age is really important. So in primary schools, we've got quite a good model around that, I think. Secondary is the challenge, because young people kind of choose where they want to eat and what they want to eat. And I think it is quite challenging. But I think the food schools audit that I mentioned is going to help in terms of pushing the quality up. How young people make that choice is going to be really critical. We've got a really interesting kind of piece of work we're doing right now with Marine Academy, where we've got one of our local chefs, Peter Coulton, working with us to design a nutritious meal. And we're going to have a nutritious meal day in January, and we're trying to directly compete with takeaways on that one. And we're going to kind of we're going to take learning from those young people around what they felt about it, and the learning from that we'll use to try and push out both into outlets in the city, but also back into schools. So I think we've got to hit head on the competition, if you want, around young people, what the choices they make. But it's going to be quite challenging, but we want to do that.
Thank you. Ian.
Oh, thank you, Chair. Yeah, it's a great report and a great presentation. Thank you for that. I suppose the value in it, or the value I'd seen in it, was individuals can be successful with, in what their choices about lifestyle and what their weight would be. So I suppose the fact that people's relationship with weight and food is very complex, as you've pointed out, and it has such an impact on particularly young people throughout their life. I mean, it's, this kind of investment will make such a change. So I think it's more than welcome. But I think the fact that the attitude to it is that individuals will. I remember some years ago we did work with troubled families, and just having that emphasis on them as individuals had a huge impact on them. And I kind of see this the same way, but I think it's important that we don't have any pre-ideas about what success will be. Success will be how each individual sees themselves rather than how, because we're all under this huge pressure of media dictating how we should look or how we should feel or how we should entertain ourselves. So I think, as you rightly point out, it's very complex and it's very difficult. I mean, it's a great programme. 10 years, I'm sure it'll have a huge impact. But there's all these other elements that come into it, like media and peer group image and bullying, as you rightly say. So, yes, it's really welcome. But I think we need to emphasise on individual success will be what's successful for them. If that makes sense.
So my one point I'd make on that is just that what I say is I completely agree with that. I think for the system to create the conditions for those individuals to achieve that, the success criteria gives the system the direction of travel. So I think what we're saying is like, if we get anywhere near where we're saying we want to get to, all of that will happen. But we absolutely need to take account of the fact that individuals and families are different and different things will be working for them.
Thank you. Zoe?
Yeah, so Ian stole my social media. That's what I was going to say. So I knocked on a door a month or two ago at the beginning of the school term, and the lady told me that she'd been told by her school that her child was overweight, which is fine. I mean, the child didn't look overweight to me, but I guess you stand on a scale, it tells you something different. This is a family in Honecknell who have no money. It's getting worse. Their money is getting lower and lower and lower. Places like Iceland are going to sell you food a lot cheaper than Morrison's or Tesco's. I'm a chef in a previous life, and I used to do like recipe bags and give them out to food banks and things like that. But without the education behind it, we're just telling them what to do. We're just telling people what to do, and they don't like that. You can't tell someone that their child's overweight when they don't have the money to feed them properly, because they're going to feel guilty. And what happens when people feel guilty? They eat. So I think it's a great thing, but we're pricing people out of the market constantly. So we can't tell parents what they should be doing to their children if we're not helping them to do it. Is kind of where I'm at. And also, I know this is a national thing, but the social media, we need to get to grips with that, because are we doing the weight the other way? Because there are loads of children underweight. So are we managing it both ways?
So both extremes are kind of part of the plan, just to confirm that, sort of underweight and overweight. We haven't sort of stated that in there, but I mean, I think what you're saying is absolutely right, and I think this is where the challenge is. I think into creating conditions which provide a different sense for people. One, that it's less stigmatising, but two, that there are things that are maybe they might be able to engage in or do, as well as the issue about food. So there's parts of the work here which is looking about what are the sustainable food choices, if you want, which are affordable and can be brought to some of our communities in ways which mean that they're taken up. That's quite challenging, but it's not going to be done in a year. I think the frustrating bit here is that we can get drawn into trying to do quick wins quickly, and we want to do that because family stories are very difficult to hear. So we need to do as much as we can now, but we still need to look ahead and sort of create some of the conditions so things can change better in the future. Sorry, did you want to come back?
Sorry, Zoe, we're really, really well over time here, and we've still got this from harm to hope coming up. This is something that obviously, because it's a 10-year programme, we'll be needing to have feedback from it periodically. So it won't be something that Dave materialises now and we never see him again for 10 years. I'm quite convinced of that. Natalie.
Thank you, Chair. Yes, just on the back of that, I think cooking programmes, a bit of a sort of something, be in my bonnet really about in schools not necessarily having the opportunities for young people to be learning to cook properly, but also thinking ahead, you know, in terms of as families, you know, cooking is fun type courses, opportunities to learn cooking on a budget, and trying to support them. There is an organisation, Food is Fun, and working on that around the city, I'm aware. But obviously, if that could be rolled out a bit more than it is, then I think that would help. That's sort of supplementary to what Zoe was saying. My main question is about the breastfeeding side of things and thinking about those early starts. There's obviously been a reduction in the amount of time spent by health visitors seeing new parents, and the support that might be given to them in terms of the amount of checks they have. We spoke briefly about COVID, but this was happening pre-COVID. Breastfeeding support, obviously the research is there that breastfeeding is the best start in terms of trying to reduce the obesity and also help from a health perspective, giving those vital that goodness to begin with. So how much work is being done, or is there going to be more support for those early years and those early starts, so that our parents, and I say parents because it may be the mum that's breastfeeding, but the partner and supporting family network need to be there supporting as well, because it's can be peer pressure and other pressures are going on. How much support is going to be given to help those with that early start, important start of being able to breastfeed, both at 6 to 8 weeks, but carrying on further up into a year. And because we're seeing that the reception year is when the obesity is already there, so it started in those very early years.
So the success criteria that I just mentioned has got that right at the top of the one of the key things. So as a whole system, the whole system needs to be focused on that being one of the absolute key kind of outcomes we want to see. So it's going to go harnessing the whole system and collaborative advantage we get from that to support that. I'm conscious of time as well here. So I'll just say, the only other thing I'd add to that is that with the new Family Hub Start to Life initiative as well, this is part of that. And we have an infant nutrition group in the city that will support that piece of work, both through the Family Hub Start to Life and through this plan as well.
Thank you. It certainly sounds as though we'll need to have updates, and we need to think about perhaps performance indicators, etc. So I think leave that with us at the moment, and I think we need to look at how we monitor what's happening. And a 10-year plan is obviously quite a long plan, but I think we need to think about where the performance side of things comes in. Okay, so we'll do that. Dave, thank you very much indeed, and I appreciate it's a large subject to rattle through, so thank you for that. So, Gary, we move on to you now, and harm to hope.
Thank you, Chair. So, as you'll see from your papers, Harm to Hope is the government's new strategy for addressing drugs. The two bits that pertain mainly to the local level are the delivering a world-class treatment system and local oversight and governance of that plan to increase the treatment system. Someone earlier was talking about spice and experimental drug use as opposed to problem drug use. That's kind of also being tackled, but really at a local level. So that's part of the demand reduction strategy, where the government are going to they're doing quite a lot of research, and they'll be announcing and delivering school-based prevention and intervention programs alongside reviewing criminal justice responses to certain types of drug use. But at the local level, the main issue for us is we're getting quite a lot of money over the next 3 years to essentially rebuild the services that we've lost. We lost during austerity over the last decade. The government are quite prescriptive about how we spend that. So in particular, specifying things like increasing commissioning capacity, increasing governance, because that's related to increasing safety, and also naming particular staff types that have left and that they would like to replace. So in particular, nurses, specialist medical practitioners, psychologists, that kind of thing. But essentially for us, it will deliver 55 additional posts over the next 3 years, mainly in years 2 and 3 when we get the larger part of the uplift. But it will enable us to reduce caseload sizes, which are currently very high. Although we've actually been quite good because the Alliance mitigated a lot of the effects of austerity. We've been able to kind of stay within limits for things like waiting times. That has meant that our staff are carrying very large caseloads. But essentially, it's a kind of good news story because it does come with this significant investment. I think it may be better if people want to ask questions rather than me just repeat what's already in the papers.
Thank you very much indeed. I mean, it's a very welcomed paper that means that we are going to be able to tackle this a lot better. As you say, sort of austerity has damaged a lot of the systems that were out there, hasn't it? Certainly. So anybody got any questions they want to ask Gary? I mean, I noticed that it's saying that there's got to be a partnership drawn up, and certainly the top of that partnership is elected members. So I'm presuming, John, there may well be, say it's members with a plural, so I'm presuming we're looking at cross-party, there's going to need to be some cross-party representation. Have you got any insight into that?
I haven't actually, Mary, but I mean, it should be cross-party, definitely, because, you know, this is not a party political issue in any way. It's public health and health of our people and health of our city. So I'm sure we would all support that.
Good. Anybody, any thought? Pauline?
Thank you, Chair. Can I just ask, how closely are you going to be working with organisations like Hamels House and Trevi?
So Hamels House are part of the Alliance. They are receiving a significant proportion of the new money. One of the things we were explicitly allowed to do was raise the pay of the lowest paid staff, and they are at Hamels. And so this, in the first year, Hamels' staff will be levelled up, so they're on a par with the staff from other agencies. And then in years 2 and 3, they are receiving a significant increase in the numbers of workers, both for adults and young people, because they provide a young person's service as well as an adult service. We are, regarding the earlier question about young people experimenting with drugs, we are also investing quite heavily in the SHARP young person's drug service. In particular, we will be employing a specialist CAMS substance misuse worker 2 or 3 additional caseworkers, but also more staff deployed for prevention. So some staff in the zone, and as I say, in Hamo's house to kind of prevent new joiners, as it were, try to turn a tap off. Yeah, so to answer your question, Hamo's are a signatory to the alliance, and they are getting a significant proportion of the money. The monies will all go via the alliance, but the bulk of the money goes to Hamo's Harbour and the Live Well Complex Needs team.
Thank you, Chair. What about Trevi?
So Trevi is a national service, not a local service. So they're not commissioned by, we don't commission Trevi. They're if you like, an independent. We would spot purchase, but they're not part of our commission services. We don't have a contract with them. So there's no kind of no opposition to it. They're just not part of our contracted services.
Sorry, Anna, do you want to come in on that?
Yeah, so just for clarity, Councillor Murphy, so we do commission Trevi through our children's commissioning team, but not necessarily through public health. So they are commissioned, and certainly we'll be looking at making sure that we align with any initiative that public health colleagues are delivering with our other commissioning agenda.
Yeah, sorry, I wasn't clear there. I meant they're not a public health commission service. They're not. The council do commission them. Yeah, apologies for that.
We're talking about a lot of new posts, etc. And are we confident that we're going to be able to fill those with, as we would want to do? Because obviously this is a very important role that we're looking at, really.
Oh, so that's a very good question. So obviously the entire country is getting this new money, and so we're all recruiting at the same time. And as with other health and social care professions, we've seen older, more experienced workers leaving. So it is going to be very difficult. So what we've agreed as a region and locally is some innovative ways to do recruitment, to have a kind of peninsular workforce development program, to look at apprenticeships, to look at kind of how we help people with lived experience that have been through the system, maybe joiners, employees. So we're trying to be as innovative as possible. It's more difficult when we think about pharmacists and nurses and doctors, because the whole of the NHS is trying to recruit them, and it's going to be a challenge. But Plymouth, as I'm sure you know, is seen as quite an innovative place to come. The Alliance itself has been a very kind of successful thing. We've attracted lots of grants through that. So in the bits of recruitment we've done so far, we are able to recruit. How long that will be sustained is kind of anybody's guess as everybody else ramps up their recruitment. But we are trying to mitigate it through partnerships with our neighbouring authorities.
One of the things that we've obviously heard earlier on is that Plymouth has an higher than average drug taking population, and obviously there's a lot of older drug takers who have got comorbidities, etc., etc. So are we confident that we will have enough capacity to deal with people? Because I'm not 100% sure how long somebody would have to wait before they went and got a service from Harbour or whatever. So is this going to really make sure that people, if they wish to go for treatment and to help to recover, that there is going to be that capacity?
Yeah, so even during the period of austerity, about 97% of people were seen within the prescribed government waiting times. But that was done at the expense of workers carrying very large caseloads. So in the initial phase, to increase safety, both for workers and for the people they're working with, a lot of the early staff will be about reducing the caseload size, because that increases safety, reduces risk, and it also makes it a more attractive place to come and work. But yes, so demand for drug services, or demand for, if you like, the heavy end of drug services, not for drug services per se, but the kind of heroin end, it is falling because, as I said, there's been no major new heroin epidemic since the early 1990s. But the nature of drug use is changing. It's much more about polypharmacy, and it's much more about people accessing drugs on the internet and that kind of thing. But yeah, we are confident that this will give us sufficient capacity to deliver a much better quality service and much shorter waiting times. Although I stress we have never really exceeded waiting times to any great extent.
Thank you. I've got Ian and Jemima, and then I'm going to, Natalie, then I'm going to bring it to a close then.
Very, very quick one, really. What's the long-term view for this money? Is it a one-off initiative that, you know, in the past we've experienced building up a need and then the funding disappearing? So can you just say a little bit about how long-term the funding is and whether these new positions will be ongoing? Thank you.
Yeah, so obviously this was announced under a previous Prime Minister, or to the Prime Minister before the last Prime Minister announced this. And we were told then that this was a 3-year escalator and it would then become permanent funds. And we have been told actually this morning that at least year 2 is guaranteed. And there are no indications, I think the phrase is, there's no indications that they are not going to follow through on the promise. So we are planning on the basis that this is still a 3-year escalator and then will become mainstream. So it will take us from where we were to the new level, and it will stay at that level as long, having regard to the fact that this is part of a comprehensive spending review and they last 3 years. So I guess it's as certain as these things are ever certain.
Thank you, I appreciate that, and I appreciate you haven't got all the information. But you know, as I say, I've seen these initiatives happen in the past, and I think it would be, please keep us informed, because this is I find it very difficult when you build up that need for vulnerable people and then the funding disappears. And, you know, given the economic situation that we find ourselves in, it's quite likely to happen. Thank you.
Right, Jemima.
Thank you. Forgive my naivety, but can you explain what you mean when you're saying about drugs via the internet?
Yes, so a lot drug markets. So there's your traditional drug market, which are often called county lines now, where people physically move into an area and move drugs around in gangs. But people also buy stuff on the internet. You can buy pretty much any drug on the internet, on the dark web. And that is literally, I mean, everybody thinks it's someone sitting at home with a credit card. And to some extent that's true. But it's also criminal gangs buying lorry loads on the internet and importing those. And they tend to be drugs like benzodiazepines, like diazepam. And of course, when you buy them, it's not always certain that they are diazepam. There may be something else. It's a bit like the earlier mention of spice. Well, when spice was introduced, it was a particular chemical formula. It's no longer that formula, but spice is now an umbrella term for a whole group of drugs. And so very often when people present, they'll say they've been using, let's say, spice, but the worker won't be certain what type of spice they've been using. That could be one of several formulations. But these days you can buy anything on the internet. We've even encountered, you can even buy, you can get antibiotics from your drug dealer if you've got a septic wound, and they're accessed on the internet. And it's very challenging for the police to police that to stop the supply. It's worthy of note that spice is an extremely popular drug in prisons, and you know that's a secure environment, and they're still able to get drugs in.
Is it something in particular that young people are doing, or is that not the case? I'm saying buying drugs on the internet.
Most young people get their drugs through friendship networks and older siblings. So, yeah, most young people don't know a drug dealer as you would kind of picture one in your mind. Most of it is done through friendship networks and older brothers and sisters, and most young people don't use drugs. Most young people don't experiment with drugs. They experiment with alcohol, which of course is a drug, but they don't experiment with illegal or grey market drugs. It's still a minority that do that, but it's quite a large minority. And most of those young people will not go on to use drugs throughout their life course. It is literally a phase of experimentation alongside when they experiment with sex, they experiment with alcohol, they experiment with drugs, and most of them kind of move through that. Yeah, does that answer your question?
Yeah, it does. Thank you.
Thank you. Natalie?
Yes, just a very quick one. Thank you, Chair. It's just regarding apprenticeships, not a question. It's more it's sort of a statement or hoping that actually, yeah, there may well be more apprenticeships, because I know from when I've seen job adverts, there's lots and lots of jobs that come up for specialist workers, but they're talking about a number of years of experience. Well, people don't get experience unless they're actually working in something. You've got to start somewhere, and if we don't start people with you know, sort of, unless it's lived experience that they're asking for, but if it's actually through training, then we've got to start somewhere, and that's hopefully how we're going to then grow our specialist skilled workforce and keep them within our city.
Gary, I don't really expect you to answer that at the moment, because presumably we need to be looking at what City College and places like that can help put into their programming to help raise levels on that. From my perspective, one of the aims there are saying delivering a world-class treatment and recovery system, and you've got a whole load of asks and expectations.
They are what came from the government, so they are their expectations.
Exactly. So then
of the money.
You're saying about how the partnership will work, and again, there is I'm just trying to think of, there's sort of 7 or 8 statements that you're going to be doing. So it's really, I suppose, from this committee's perspective, is the monitoring of that and how you aim and get that provided, and how you're showing us that that's what's coming out of the scheme, etc. So I think what I'm going to ask is that we need to work on how you can report back to us so that we can monitor that these are being achieved. So I think let's watch this space, and I think we need to think about how we can monitor, just like we monitor the alliance contract, etc. I think I would be wanting to see how we do that, and obviously we'll work with you to get those sort of how we monitor it worked out and finalised. All right, but we'll look forward to speaking with you about that. A really impressive scheme. I mean, anything that helps to support our young people and our older drug taking population. I mean, to me, it's got to be brilliant, and I think it'll be worthwhile to see how we achieve those aims, that very admirable aims, and we'll see you again soon. All right, Gary, so thank you very much indeed. Looking back, I mean, over the years we've had various projects, haven't we, come through scrutiny and whatever, so you know, let's hope we get some
just before I go, Chair, so in terms of accountability to this committee, I think what the policy is asking us to do is to set up the Combating Drugs Partnership, which Ruth is in. Ruth will be the senior responsible officer, and she's in the process of setting that up. And that committee will kind of oversee the groundwork. And then what's needed is for maybe the SRO from that committee to account to this committee. If you see what I mean?
Yes, totally. We will look forward to working with whatever we can end up with set up. But yes, as you say, there needs to be a reporting back to us. So we look forward to that. Thank you very much, Gary, for joining us. Much appreciated. Okay, now we've got Rob Nelder standing by, looking at health indices, etc. Because one of those things that we'd always used to do before dear old COVID hit us was to look at public health indices during our year to see how we were doing in Plymouth compared to other things. Now, Rob, is there anything you want to add to that? And I'm very disappointed. You've hidden the skeleton. I'm really quite disappointed. You know, he's out of view. What have you got on him today? What fancy hat? And has he still got his mask?
It's not in full Christmas regalia yet, but has got the mask
Ah,
on.
that's better.
Yeah,
We can
I mean,
see him now.
what I wanted to say, I mean, and again, I'll keep this incredibly brief because I'm aware of the time, is that what we've tried to do this time, and I think it was Ruth's suggestion, is that rather than talk about public health indicators at the start of the session, what we've been able to do, I think, is through the conversations, is have an update from the public health team on some of the indicators that you will probably have seen mentioned in the report that's been produced. And it's probably been a better way of doing it, because otherwise what we would have done is focused on the minutiae of the data, and what you wouldn't have got necessarily was an overview of the initiatives that are taking place in the city to address some of those indicators, if you like. So I think it's been the right way to do it, to focus on the initiatives and the programs in the city rather than going through indicator by indicator, which can often be a bit turgid and dry. One of the points I did want to make, though, is the fact that the former Public Health England used to produce a general health profile for Plymouth, and they don't do that now. So what we've done is we've tried to produce something similar to that, which we can produce on an annual basis and come back to the committee with. But I think from the conversation this afternoon, it's actually more useful to talk about the programs and the initiatives that we have in place in the city and make reference to some of the indicators rather than having an indicator update per se that we talk through line by line. So I think that's probably all I wanted to say. But obviously, if people have got questions on any of the indicators, I'm conscious that we haven't necessarily got the time to go through them now, but as a team, we can respond to any queries maybe outside of the meeting if you wanted us to do that.
I think certainly from the conversations that have happened here this afternoon, there has been that value into looking at things in more depth. So yeah, I think that's right. So thank you to you and the team for putting this together. I think Ruth, certainly it's been of great value. I think it's given everybody that perspective as to health in Plymouth is a lot more complex than perhaps some people think it is. It's certainly not just a visit to the GP or a visit to the hospital. So thank you for that. Jemima, have you found this of value from the children's perspective as much bringing it all in generally?
Yeah, definitely. You mean on my committee, doing it this way? Yeah, absolutely.
Thank you. Okay, I'm going to bring this bit to an end now and say thank you to everybody who's inputted this afternoon into that, Ruth. Please thank the team. It's been really of value. And I'm now going to move on to Jo, and who's brought Matt with her. Thank you. Both of you very, very welcome. At the moment, this is in a part 1 meeting, and unless we need to, we will stay in that. But if at all we are going into territory where it shouldn't be part 1, we will go into part 2 quickly. All right. So, Jo, the floor is yours. Everybody's had the papers that have come about the West End hub. It's come as a to follow paper to us, and we did catch up a little bit. When was it? Tuesday. Monday even? Monday? I've lost track of days this week, I must admit. Monday, it was Monday, wasn't it? So, Joe, the floor is yours for the moment, please.
Lovely, thank you very much, Chair. Oh, that's loud. So, hi, I will just introduce myself briefly because there are lots of familiar faces, but some not. My name's Jo Tell, Director of Commissioning for NHS Devon. I've brought Matt with me. Do you want to introduce yourself, Matt?
Yeah, thanks, Joe. My name's Matt Ward. I work for Plymouth City Council. My job title is Head of Strategic Development Projects. I've met some of you before, but not all of you. And I work in the Economic Development team, reporting to David Truffin and Anthony Payne.
Brilliant, thank you, Matt. So you've all seen the paper that's in the pack. It's quite a short paper, so I'm going to make the assumption that people have read it. But I did just want to draw out a few highlights, particularly for those of you who've not been maybe on this journey with us all from the beginning. So first of all, I want to say that the West End Hub is part of a national programme, so part of the National Caval programme. We're one of 6 pilots, and indeed we're one of the largest of those pilots as well. Also true to say that we are the most advanced of those pilots. The National Caval Board, so there's a national board that reports up to the department, and we report in turn to them in terms of our progress. They'd expected to be able to secure capital funding through the last spending review, but unfortunately weren't able to make that case in time for that spending review. But since then, we have received revenue funding of approximately 2.6 million, which we've used to get to this place in the Caval project. So broadly speaking, that's enabled us to have a project team to enlist expertise from outside of both NHS and indeed local authority, but it's also paid for mine and Matt's and others' time to enable us to do that. But we've also been able to use some of that money as well to get us to the place where we needed to in terms of developing the full business case and also being, as we're terming it, shovel ready for the project. So we've been very encouraged through obviously that revenue funding that we've received nationally. And the ask from the national team was that we work up a full business case so that as soon as capital became available, we would be able to push the button, push the green light on the project. So we have been informed that there is no capital currently available in this spending review at the moment. Of course, we don't know what will happen tomorrow, so we're awaiting the autumn review. But at the moment, the National Caval Board are making a proposal, a business case, that they will be sending to the Treasury for inclusion in the next spending review. So it's very much still very live from a national perspective. Absolutely supports national direction of travel around things like the long-term plan and the recent Fuller stocktake, which was a stocktake undertaken by Claire Fuller into general practice, and really promotes the idea of integrated services in health and wellbeing centres such as the one that we're developing for Plymouth. As part of developing the proposal, obviously we've undertaken quite a lot of engagement with the public, as you would expect us to understand what's important to them, what would help them access services, what improvements that they would like to see. So as part of that, obviously we have talked to them about our proposals, but I do want to say that we're always really clear that we didn't have and needed capital to enable us to undertake this project. The full business case itself, as I said, has been developed. It's been signed off by our local Caval steering group. It's also been to the Integrated Care Board, so the NHS board in Devon, who gave us approval to send that to Region to go through their process. And whilst it's not formally been rubber stamped by either of the two organisations, the feedback that we've had from Region is that it meets all the criteria they would expect of the business case, except for it having the capital funding. And that would be the same position that we're in locally with our NHS board as well. So we're currently waiting, as I said, we're currently waiting the autumn announcement tomorrow to see if that gives us anything that we could work towards. But we are keeping the project going at the moment until we receive any announcement around national capital funding. So I'll pause there. I think we're very happy, Chair, to open it up for questions at that point.
Thank you. Anybody got any questions they want to ask? Jemima.
Thank you, Chair. Yeah, we were looking at healthy life expectancy in the city earlier in this meeting, and guess which ward topped the chart for poor outcomes? The very ward in which this centre is meant to be being built. I wanted to talk about a word that's been introduced to the lexicon when we talk about this health hub, a word introduced by one of the city's Conservative MPs, Johnny Mercer, unchallenged in an interview with Plymouth Live last week, where he talked about the health hub being simply an ambition. Do you relocate businesses for an ambition? Do you bulldoze swathes of land for an ambition? I followed the development of the health hub, maybe not as closely as other people in here, but I must admit I've never heard the project referred to as an ambition before Mr. Mercer said it. Is that a word you, Councillor Mahoney, recognise? Or indeed anybody else here? Is that a characterisation that you recognise, that this was merely an ambition? Because that's a very loaded word.
I mean, I would agree with you that you don't start doing the things that have been done, because actually it actually brings out what the public think is worse in public services, that money has been wasted if we're not going to get the final object. I mean, I am convinced we will get it one way or another, with a bit of a delay. But I mean, you know, to say it was an ambition when you spent £2 million or £2.6 million of taxpayers' money that's come through the NHS. The sad thing is here, really, there seems to be a big lack of joined-up thinking within the NHS. I mean, I'm prepared to say that because that is where the money has come from to go where we are now. But it seems like there's no more money to follow. Although I believe somebody is saying that, you know, the money should have come out of an allocation that's already gone to Devon ICS. Well, that may or may not be the truth. Somebody else, of course, wrote in the Herald and said, well, was this ever signed and sealed? Was there a bit of paper?
Can I just suggest,
know.
I think we ought to move to part two. I think we're perhaps treading into commercially sensitive areas. So I'm going to read that magic sentence which says, to consider passing a resolution under section 100A bracket 4 of the Local Government Act 1972 to exclude the press and public from the meeting, and for the following item of business on the grounds that it should be likely disclosure of exempt information under as defined in paragraph 3 of part 1 of the schedule 12A of the Act as amended by the Freedom of Information Act 2002. Can I have a proposer for that, please? Thank you, Ian. And a seconder, Viv, thank you. Need to wait a couple of seconds for it all to catch up. And if somebody can tell me when we are live. Okay, right, folks. So this is the proposal that I have, and I'm going to be asking for a vote on this. The committee reaffirms its strong support for the West End Health Hub project, part of the National Cavell Centre programme. The ICB should consider funding the project through their capital programme unless this risks the maintenance of critical health infrastructure. That at a future meeting of the committee, the ICB reports on the use of the capital funding in Plymouth. The committee welcomes the offer of the Right Honourable Robert Jenrick MP to visit Plymouth and to broker a meeting. The committee requests that his successor honours this offer to facilitate the meeting between the ICB Council and, ICB Council, affected GP services, NHS England, to identify innovation or creative solutions to move the project forward. Are we happy to support that? So can I have a vote on that, please?
Could we make comment first, please?
Right, yep.
Could I just ask that as soon as this, like, we're finished, not necessarily tonight, but perhaps tomorrow,
we could just have a copy of that proposal, type written down, because it was rather long. Yeah. Yeah, fine. Thank you,
yes, I
Chair.
quite agree with
Yeah.
that. But it's basically saying we want to know what's happening.
Yeah,
And I think
yeah.
certainly
Quite agree with
asking,
it, yeah.
asking
Just, I'd like to see it
the
written down.
Right Honourable Robert Jenrick's successor to come down. I think that would be really, really useful to as well. So in principle, can I ask for a support for that, please, folks? Thank you. Anybody disagree? No? Okay. And we will publish that as an outcome of this meeting today. Joe, can I say thank you very much indeed to you coming along to explain matters. And Matt, thank you for being available to explain PCC's point of view. I think the other thing is we do need to ask that comms does come and propose a good a good appropriate statement. I think that would help explain matters as well. So that needs to be a recommendation as well. Sue?
Would it be okay for this committee to see the content of that statement prior to it going public?
Anna, your thought on that?
So I think I think I've heard loud and clear in terms of comms. I think there is something which is around a joint communication in this respect. So I think, Chair, there's an action for myself or officers in my directorate to work with Joe to pull that together. So yeah, I'm happy to share that.
Excellent. Right. Okay, folks, we haven't quite finished the meeting yet, folks. We've got, I'm trying to find my pieces of paper now. Yeah, fine. There's a tracking decisions, which is there. Okay, no problem, Sue. That's great. Thank you very much for being here. So if we look at the tracking decisions, which have all come out, I think, Elliot, they're all there, and whatever, there's ongoing work on some of them. Any of your, do you want to make a comment there?
Yes, thank you, Chair. The majority have been completed, as you can see. There are 2 currently in progress. One is the drafting of a letter from our recommendation last meeting, and another one is from Daffyd Jones, who is going to supply some further video material, which I'll circulate to the committee as soon as it's received. Other than that, they're all complete. Thank you.
I think it became impossible for us all to go wandering off to GP surgeries. I think with the work that GPs are doing at the moment, I can see the logic in that. So we'll get that, whatever video there is, if we can send it out to everybody so they can have a look at those clips, that would be really useful. Thank you. And the work programme, as if there is anything else that you want to be adding to the work programme, please let us know. But I think as I said to you earlier on, the whole idea of a mental health committee, and as I say, 2 separate sessions. One I'm taking it up to the age of 25 because that's the education, health, and whatever is the third bit of that thing is, and I can never remember that, that we need to be looking into that, and then into adults. And I'm minded to include dementia in there. I'm minded to include what Pauline asked us to include in there, and you're going to have to remind me because that was 3 hours ago, 3.5 hours ago. So, Pauline.
Thank you, Chair. As I requested for the children one to include service children, because obviously they get, they're always under the radar. In the adult one, could we also include a bit there on serving personnel or veterans, or
of course, I'd automatically put that through.
Is that okay? Because obviously,
of course, yeah.
Thank you.
Not a problem. That be ideal. So I shall certainly take that to our next management board to say we want to be doing that. The February one, we did ask for integrated urgent care and a 111 update, because if you remember, 111 provider was changing not supplier, I don't mean supplier, provider. So I think we need to be finding that. The other thing that we desperately need an update on is ambulance service. I think, yeah, Anna?
So I just wonder whether it would be helpful, so you know we did the whole session in terms of urgent care. I just wonder in terms of February whether you wanted to repeat that, Chair, in terms of looking at the 111, the ambulance position, what was happening across the hospital, and bring that in by way of an update, because that would give you all of that information. So clearly there was performance information when the team presented that. You'd then be able to see how the system has responded through winter. It's just a suggestion, Chair. Would bring all of those elements together in a one.
Certainly, and I think there are some things that we haven't heard about for a little while. It is in sort of adult safeguarding board. I think we do need a report, even if they aren't here. I think we need a report from the adult safeguarding board. Pauline.
Sorry, Chair. Just following on from what Anna's just said. Is it possible? I don't know how possible it'll be, but obviously we get a lot of operations and whatsoever cancelled at the hospitals, which we do, you know, for lack of staff or whatever. Could we kind of ask the question of when all of these things get cancelled, what do the staff do? I don't mean that to be rude when I say that. Could they not be deployed in another department? Could they not go into A&E? Could they not go, because there are doctors and they are nurses? I just would like to know what they actually, you know, when stuff is cancelled at the last minute, what do the staff actually do? I don't know.
I'll let Anna consider that.
So there's probably a couple of bits in that, Councillor Murphy, and maybe I'll just work with Chair outside of this, but there is something around the elective care recovery programme and having visibility around that. So I think we should bring that in. I think maybe if we joined that together, Chair, with the hospital and brought that together so that we could see where the system is in terms of elective recovery, but also then ask those questions in terms of the hospital, Pauline. I think that's absolutely reasonable to bring that together. So I'll just work with the chair in terms of that, and we'll see if we can answer those very valid questions. I mean, I can make some assumptions as an ex-clinician, but it's not my place to do that in this committee.
I mean, just another observation on my part, because obviously all the ambulances that are stuck outside A&E is that we've got all of these crews waiting, and it's not their fault. I didn't know whether there would be there's something could be done like that. We could actually relieve them if we could just get somebody there to look after those patients outside somewhere with a unit, and then they could go off and do whatever they needed to do, because for me it just seems it needs to be managed differently.
John,
I don't
do you
know.
want to come in there?
I mean, I think there's still a problem with ambulance waits, but I'm pretty sure that Derriford has, I don't know, is permanently employing a paramedic to actually manage a corridor where some of these patients are put out of the ambulances and into a corridor and are supervised by a paramedic. That's been happening, I think, hasn't it, Anna, on a permanent or temporary basis? So could this be expanded so less ambulances are sitting out there?
Yeah, you're absolutely right, Councillor Mahoney. So as part of the additional winter investment that Devon ICS put into Derriford Hospital, they've recruited additional paramedic capacity to man what they call the Halo corridor. And actually that is to do everything to release as many ambulances as possible to get them back out on the road.
Can I just say what I really think we need to do is to look at these chunks and make sure, rather than overload a normal scrutiny meeting like today, whether we actually then need to have a separate session about something like that, and that we can then have a session properly and lot the questions answered, rather than trying to put too much into a set scrutiny meeting. So I think if you can leave that with us at the moment, that Elliot, John, Anna and I and the Vice Chair look at how we can do that and have a dialogue as well with you, Pauline, on.
Sorry, Chair, just a quick one, because obviously you said that this was happening. I don't know whether, I mean, the departure lounge up there is absolutely amazing. I don't know whether maybe that could be used of an evening when, because there's nobody going to be leaving the hospital at like 4 or 5 o'clock in the morning. So I don't know whether you could use that departure lounge rather than a corridor for these patients.
So I think Councillor Murphy, probably, you know, if we bring, as Chair suggested, this into a urgent and emergency care update in terms of the work that the hospital and partners across the city planned for winter, we can then look at the plans, and I think, you know, all of these are really, you know, they're helpful ideas and suggestions. So I'm sure that colleagues at the hospital will be pleased to receive them. So if we bring that together, as Chair suggests, in a session, and make sure that we have a good amount of time to ask questions, that's probably the best way of taking that forward, I would suggest.
Okay, folks, thank you very much indeed for your patience. I think it's been a very productive session here, and I think we've all know a lot more about what's happening there. But I think, as usual, it leaves us with more questions that we will want to be asking and getting answers from. So thank you all very much indeed. Thank you, Elliot. Thank you, Anna, for doing that. And I suppose we should have said really, really welcome to you in your role post-Craig. All right, so thank you, folks. Can I just remember, folks, the camera is still rolling, so can we just sort of